All right. Good morning, everyone, and welcome. It's my great pleasure to welcome you both to the conference, this year's 39th ICP, as well as to our Foundations in Causal Inference course. And hopefully the microphone sounds okay. We're going to actually, this is going to be a challenge for Geeta and I to stay in front of the microphone this morning. So the session's both being recorded and live streamed. So we're going to stay at the podium here, although we both like to wander. And we're going to ask that when you ask questions, and as much as possible through some of the questions that we'll ask, we'll try to capture it either via the microphone in the middle of the room, or we'll repeat both the question and answer into this microphone here. So I want to start us off with a couple of questions before we really get going. I would love to know how many people are attending ICP for the first time. Great number. Welcome. You made a good decision to come. How many people are in Nova Scotia for the first time? In Canada for the first time? Great. How many people are from the US? From Canada? Europe? The Asia Pacific region? Africa? Other places? Great. Well, welcome. It's really a pleasure to have you here this morning. I'll introduce both myself and Geeta in just a moment, but by way of conflicts of interest, I am an employee of Johnson & Johnson. I also hold stock, but nothing that we'll talk about today pertains to anything related to Johnson & Johnson. My name is Josh Gagne, and I'm the global head of epidemiology at Johnson & Johnson. I also have an adjunct appointment at the Harvard T.H. Chan School of Public Health. And I'm joined by Dr. Geeta Iyer, who's a research specialist in the Department of Population Medicine at the Harvard Pilgrim Healthcare Institute. And it's our pleasure to be able to talk to you today about some basics and foundations in causal inference. And I want to very briefly tell you how we're going to spend the next 4 hours of our lives together, which is I'll spend a few minutes talking about the overview, and I'll very briefly introduce a case study, which will thread through some of the presentation this morning, and then we will engage with a bit more deeply towards the end of the session through an activity that we'll do. And then I'm going to hand it over to Geeta, who's going to introduce the basic concepts of causal inference, talk about key terms and assumptions, as well as concepts that really do build that foundation in thinking in a causal inference framework. We'll take a quick break, and we believe that there'll be coffee available all morning, so you'll have a chance to recaffeinate. We think the coffee is downstairs. We can remind you as we head into that break. And then when we come back, we're going to talk about DAGs, or directed acyclic graphs. So we'll spend about 45 minutes doing that. We'll take another quick break just to re-energize, and then we'll spend most of the second half of the session this morning introducing what's called the target trial framework, and then we'll jump into the interactive activity that we'll do together, where we'll actually specify a target trial. We'll draw out our assumptions in terms of a DAG, and then we'll design an observational study to emulate this target trial that we design. Please feel free at any moment to ask questions. We do want this to be interactive. We want to make sure that everyone's tracking along. In certain parts of the session this morning, we have questions built in to kind of check to see how folks are tracking, but feel free to interrupt us at any moment, please. By the end of the course, what we're hoping that you'll take away is a fluency in the terminology, notation, and the basic concepts of causal inference. And we're also hoping that you'll be proficient in the use of directed acyclic graphs, both in terms of how to draw them to specify an underlying study question and the assumptions that you impose on it, as well as how to interpret DAGs to detect and discover potential biases in a study, either that you designed or that someone else designed. And then we also will hope that you walk away with at least an introduction to the target trial framework, how to apply it, and then how to both implement and interpret observational studies within that framework. So before I hand it over to Geeta, I want to very briefly just introduce a case study that we'll talk about a little bit as we go through, as I mentioned, and then we'll focus very much on in the latter half of the course. And the example is around statins, so very old drugs at this point, but we're thinking about two statin medications, rosuvastatin and atorvastatin, and we're going to be thinking about how to design a comparative safety and effectiveness study to compare these two statins. So statins are drugs that are used to lower cholesterol to prevent cardiovascular outcomes such as heart attack and perhaps stroke as well. And we're going to focus the question specifically in individuals with type 2 diabetes, a risk factor for some of those cardiovascular outcomes. So we can certainly get into this more, but just wanted to frame that up a little bit for you as we progress into the first session here, and then we'll revisit this later on. Is everyone comfortable with the plan for this morning? Any questions? Very good. Okay, without further ado, I'll hand it over to Geeta, who will start us off with the introduction.
Oh, that's all right. Okay. Hello, everyone, and welcome to the course. As Josh mentioned, that we both like to wander a lot, so it might happen that I move my head here and there, and I move my body, but don't worry, I got you. Okay, so you're gonna be here. We're all gonna be fine. We'll go through this next 15 minutes of our lives together, and hopefully you will come away with an understanding of what causal inference means. Why does this seemingly scary word, causal inference, is nothing but just a way of thinking about research questions. So that's my hope to demystify demystify causal inference for you today. All right. Now, this is going to be the roadmap for us. This is going to be the roadmap for us today. So we'll discuss what's a cause in very normal layman terms. Then we'll move on to talking about a very specific formal framework of discussing causal inference. We'll go into the discussion of how causation is different from association that you might see in the data. And we'll talk about how and where can the association we see in our study be equal to the causal effect of an exposure on an outcome. So for all of you who want to know a little bit more about causal inference, it's an excellent textbook. It's available free, I think, on HSPH website, written by Miguel Hernan and Jamie Robbins. It has everything from introductory concepts, and it takes, and for anyone who is already familiar with these concepts, it also has a bit more technical explanation in it. Before I start the lecture, actually, I just want to let everybody know that, as in all courses, this is just a 15-minute lecture, right? So there'll be some things that will be easy for you to grasp within the 50 minutes, and there'll be some things that I want to marinate, for you to marinate in your head, all right? So those might be things that after the entire 4 hours are over, you might understand a little bit better. So feel free to interrupt me at any point and ask any questions that you have. I hope that's okay. All right, let's start. So most of epi research can kind of be classified broadly in 3 buckets. The first one is descriptive, second is causal inference, and the last is prediction. You can think about this as a way of going through the cycle of we knowing more about a disease. A new disease comes up. The first thing we want to know is, all right, who's getting it? What is, what are the kind of population that are getting it more frequently than others? As you can imagine, during the COVID pandemic, that's what the first studies came out to be. Just like, what were the risk factors for getting COVID in the first place? The next step would be to plan and see what are the causes of a particular disease. Maybe one of the risk factors is actually a cause. Now, here we are thinking about potentially framing that causal effect of an exposure and the outcome with an idea to intervene on that cause, because that's usually why we do causal inference in the first place. Like if there's something that we think is a cause of an outcome, we would like to intervene on that to either reduce the risk of the outcome, or if it's a beneficial outcome, increase the probability of that outcome happening. Once we are a little bit more secure in the causal inference, we go into the idea of prediction, right? So we are secure and we know enough about the disease and the underlying causal mechanisms. Then how about we try and predict which a patient perhaps in front of me who has a certain set of conditions, what is the likelihood or the probability that that person is going to get that particular condition in the next 10 years, in the next 15 years. You might have seen this kind of framework for cardiovascular diseases, cancers, and so on. So here we'll be focusing mostly on the causal inference part. All right, it's a very basic question. What is meant by cause? And I would love for you guys to answer, if that's okay. It's all right. Everybody here has a similar level of understanding. Tell me what is meant by a cause in plain English. Yes. Exactly, right? It's a reason why something is happening. It's the reason for an effect that's happening. So when we think about causes, I want to pose a question to you. All right. So this is a scenario where Harry takes a tablet on the 1st of March. Harry dies on the 3rd of March. Can you tell me whether the tablet caused Harry's death? No, I see a lot of shaking heads, right? So no. What other information perhaps do you need here? Something else happened, that's a possibility, yes. That's a good point, right? What did Harry take on the 2nd of March? What was happening on that day? Maybe he just got hit by a car. What's that got to do with a tablet? But when we are focusing on the causal effect of the actual tablet, regardless of what happens after that, we need one additional information to really cement whether it's a causal effect or not. The counterfactual, right? If Harry had not taken the tablet, what would have happened? Because right now we're focusing on the specific relationship. Our exposure is the tablet, our outcome is death. So if Harry took the tablet, he died. And if he had not taken the tablet, he would have died. Now, if you have both pieces of this information, now, if you're specifically talking about the tablet and death, you could perhaps come to a conclusion that yes, whether he took the tablet or he didn't take the tablet, it has no impact on whether Harry died or not, right? So there is no causal effect of the tablet on death, at least for Harry, right? Okay, so it's an individual, I'm looking at an individual person. I need two pieces of information to be able to tell whether something is causing something else. What happened if they were exposed? What happened if they weren't exposed? Similarly, now let's talk about Ron. He's a friend, right? He took a tablet, he died, and if he had not taken the tablet, he would be alive. Now, in this case, just based on the two statements that I'm giving you, you might conclude that no, yes, that the tablet was in fact the cause of Ron's death. All right. So here is what we come to as the intuitive definition of cause. Like in our minds, when we are thinking about a cause, we should be comparing what would have happened with the exposure and without the exposure in the same person. Now, that is one way of really very clearly understanding whether something is a cause of an outcome. All right. So we compare, if only mentally, the outcome when the exposure A is present and the outcome when the exposure A is absent, everything else being equal. That's really important. If the two outcomes differ, we can say that the action A or the exposure A has a causal effect. It's either causative or preventative, depending on whether the outcome is beneficial or not. And in epidemiology specifically, when we talk about A, we are usually talking about an exposure, and in pharmacoepi specifically, often a treatment. Is that okay? All right. Now, this is basically what the counterfactual framework kind of is telling you. We are trying to understand. If you look at the line in red, you can see the outcome when the action or exposure A is present is denoted with a notation that is Y. Y is our outcome, and there is a subscript there, right? A is equal to 1. So the potential outcome if a person was exposed is just Y superscript A is equal to 1. And the potential outcome if the person was not exposed is simply Y with a superscript of A is equal to 0. Okay, so this is basically what the counterfactual framework is telling us. When we try and put cause in an actual framework, formal framework, we get to decide, yes, we can say that an exposure is causing an outcome if we have these two pieces of information. We know what happens if the person was exposed. We know what happens if the person was unexposed. And that's the counterfactual framework. Obviously, in real life, we can only observe one of these two potential outcomes. What actually happens if Harry was exposed? What actually happens if Ron was exposed? We don't really have a, we don't really have a time machine to go back and like change the exposure to look at that, all right? So is the framework clear in very simple terms? As I mentioned, we only observe one potential outcome for each individual, the outcome based on their actual observed exposure status. So if I did know both of the potential outcomes for an individual, I could find out what the individual causal effect is. If a patient receives a drug, what's their risk of a heart attack 10 years down the line? If the same person did not get that drug, what's the potential outcome 10 years down the line, right? I could get that. That is what we want to know when we are trying to prescribe a drug or any kind of medication regime to an individual. We want to know, like, yes, this person will benefit. But we actually don't have both of these pieces of information. That's just not available to us. We only can see one. We want both of these terms, both the potential outcomes, but we only see the observed one. Are there any questions so far? So I've just described what is an individual causal effect. And now we'll move to average causal effects. Well, if we can't estimate individual causal effects, can we do something about groups of people instead? That's the second, perhaps logical choice. So if you see this specific notation, what I've mentioned is treatment A has an average causal effect on the outcome Y if the expected or the average potential outcome when that entire group of people is exposed is not equal to the expected outcome when the entire group of people is unexposed. I kind of want to move. Okay, so is everybody getting why there's an average causal effect here? If treatment had nothing to do with the outcome, both of these terms would be the same. The probability or the average of, let's just say, the probability that an entire group of people receive a drug would be the same if the entire group of people did not receive the drug, because exposure has got nothing to do with the outcome, right? And that's where we know that there is no causal effect of the exposure on the outcome. If they are not similar to each other, if they're not the same, then we do have a causal effect of exposure on the outcome. Is that okay? All right, great. Please give me some acknowledgement. That's really great. It's kind of intimidating to like stand here and talk to all of you. Okay, all right. So obviously the question now is, can we do this in groups of people instead? I know we can't do it for one person. Perhaps we can do it for groups of people. Answer is no. Why not? At least not straightforward, not in terms of potential outcomes themselves. We need to make lots of assumptions before we can get to the causal effect. Now, the individual and the average is still the same, right? Like for estimating the average causal effect, I still need to know what would happen if all of you received a drug versus if all of you did not receive the drug. I still need both of those pieces of information. I don't have that, right? So this is completely unattainable if you really think about it. But that is what we're looking for. We really want to know when a new drug comes to the market, whether taking that drug will be beneficial for an individual, for like a population versus not taking that drug. One drug versus another, we are always interested in, is it a true benefit? Is it worth it to bring this drug to the market and give it to groups of people who would benefit versus not? Because this entire exercise seems an exercise in futility, but it's not, right? So what if instead of just talking about both potential outcomes in the same group, I have a proxy for the unexposed part? Let's just say I have all of you who are exposed to a drug, and I have another group who's taking a second pre-conference workshop, right? Those individuals, what if I give them the comparator or not being exposed to a drug? What about the outcomes at that point, right? So we are trying to get at estimating a causal effect by creating a control group, by creating a group that looks very, very similar to the exposed group, but is just not exposed. That's all. That's the only difference I want. Demographically, comorbidities wise, everything, you look very, very similar. It's as if I cloned you and there's a second group of your clones who is not receiving the treatment. That's what I want, right? Can we do something like that in real life? Have you seen something like that? Not cloning, of course, but have you seen something like that in real life? Sorry? Twins. Yes, I mean, there have been lots of twin studies. It's so hard to get them, though, right? What about RCTs? Right? Randomized control trials. What do we do in randomized control trials? We have a group of people, and I'm randomly dividing that group into two groups. So because it's randomly, like if I take all of you and I divide you into two groups just by flipping a coin, like you belong in group A, you belong in group B, and so on average, the two groups are going to be similar to each other with the average ages, the demographics, and all, right? Just by chance, because your probability of being in one of the two groups is equal. There's no difference. You could be in group A, but just by chance, you're in group B. All right? So RCTs are oftentimes our answer to getting at the causal question of interest and why it is considered like the gold standard. So in this case, what I'd be doing is you assign one group the treatment and one group to be untreated. The red and blue groups are random subgroups of the entire population and hence similar with respect to known and unknown characteristics. If you've ever taken an epi course, that's kind of what they tell you. Randomization creates balanced groups with relation to both known and unknown confounders, right? That's kind of what this is telling about. Like if you randomize a big enough group of people, not 10 folks, not 20 folks, let's just say you're randomizing 1,000 people. You create two groups of 500 each. The individual 500 groups will look very similar to the 1,000. If you look at their average age, the probability, like the proportion of people who have certain diseases and so on. Okay, so once we do that, we are getting at this idea of like one group is exposed. What if the same group was unexposed, and that's our control group? That's our comparator group. Is that okay? All right. So in this case, let's just say, ouch, that I've created two groups and assume this is like more than 10 people, all right? Okay. The red triangles are exposed and the blue circles are not. And what I observe is that there are 4 out of 10 individuals, or 10 to the power of something. Each circle is like 1,000 people, if only, right? So in that case, what I see is the probability that the outcome is happening in the first group, the exposed group, is 4 out of 10. The probability that the outcome is happening in the group that's unexposed is 2 out of 10. That's what I see, right? Now remember, if you see the notation, there's no superscript here. This is my observation. I'm seeing these results in real life. These are not counterfactual outcomes. I'm actually exposing a group. I'm actually, like one group is unexposed. And I'm observing both of them with respect to the risk of the outcome. This is different from the potential outcome framework, okay? So in this case, what I have is I have two pieces of information. One is the probability of the outcome in the group that was exposed, probability of outcome in the group that was unexposed. Now, the question here is, what would have happened if I flipped the exposure? Now, instead of being exposed, the red triangles are now unexposed, and the blue circles are now exposed. What do you think would be the probability of the outcome? This is an extremely simple example, so, it's not to be taken completely, but like it illustrates the point, which basically is that just because the red triangles is now unexposed, I would expect, on average, the probability of the outcome in this unexposed group to be 2 out of 10, right? Because the two groups are similar to each other. It doesn't really matter which group was exposed and which group was unexposed, because it's not the people, it's the exposure that I'm interested in, because the groups are similar to each other because they've been randomly assigned. When group membership is randomly assigned, the results are kind of, at least with respect to the outcome, are the same, whether one of the group is exposed or the first group is unexposed. In this case, we would say that these two groups are comparable or exchangeable. You must have heard about this term exchangeability. This is what it refers to, is we have exchangeability between the two groups with respect to the exposure, okay? And this exchangeability, at least at baseline, at the start of the study, is a consequence of randomization, and hence why all of us love randomization so much, right? It's this idea that like, hey, I'm getting rid of why one group is exposed or one group is unexposed. It's got nothing to do with their inherent properties. I literally just randomized them into two groups, and I intervened on that exposure to give one group exposure to have the other group being unexposed. Is that clear? So this is what is meant by exchangeability, and oftentimes, at least in RCTs, if we randomize a large enough number of people at baseline, we have exchangeability. I know it's a lot of ifs and buts, but epi is all ifs and buts, and it depends, which is very irritating when you're a student. Is that okay? All right. So I'm gonna put everything together. To estimate the average causal effect, I need two things. I need the probability of the outcome if everyone was exposed. I need the probability of the outcome if the same group was unexposed, right? That's what I need. But what do I have in observational, like in randomized trials? What I have is I'm dividing that group into two smaller groups simply through a random process, whatever that might be. And I'm assigning one group the exposure and I'm assigning the other group to not being exposed, and I have those outcomes. All right. So this is the best thing that I can do, frankly speaking, within the constraints of the natural world that I have. So in this case, I'm creating a comparator group that can be considered a proxy for the exposure group, which is in fact unexposed, because that's the thing that's the difference. It's the exposure. It's all about what happens if you're exposed versus unexposed. That's what I'm interested in. So in randomized trials, again, love RCTs. They are great. With certain assumptions, you have the assumptions that I'll talk about in the next two slides of exchangeability that we've already talked about, well-defined intervention or consistency and positivity. I can say that the association, that is the probability of y is equal to 1, conditional on a is equal to 1 or a is equal to 0. So the right side of the two equations is equal to the left side of the equations, which are the potential outcomes or the counterfactual outcomes that I'm interested in. All right. So if you have these assumptions met, you can say that the association that you see in randomized trials is equal to the causal effect. Yes, there's a question? I'll come to positivity in the next two slides. And that's, I think, more of a concern is like if you're trying to talk about the causal effect as pertaining to the entire population, you need positivity. I'll come to that. Any other questions? Why you think this is all right? Okay, I see some shell-shocked faces, but you know, it'll get better. It'll get better. I'm only at RCTs. I've not even come to observational studies. Okay, so the assumptions of causal inference, right? So I talked about 3. You have one more, just because of the nature of the data that we have. That is exchangeability, consistency, and positivity. Exchangeability that I talked about in a randomized control trial, just because I'm randomizing the groups, I have exchangeability at baseline. It doesn't matter which group is exposed or which group is unexposed. The two are comparable to each other. So on average, I should get the same answer, right? It implies a lack of baseline confounding. Remember, it's only at baseline because I am randomizing at baseline at the start of the study, right? 2 years into a study, you can't expect that there's still going to be exchangeability because people drop out. People have outcomes over this timeline, right? So the people who are left in your study at the end of 2 years, they are probably not going to be exchangeable with each other. They're going to be different people, right? So the exposure groups are exchangeable when the baseline risk of the outcome among the exposed is the same. Think about this. The baseline risk of outcome in the exposed group is the same as the baseline risk of outcome in the unexposed group if the unexposed group was exposed. That's a complex statement. Let it sit there for a while, right? Because it's the idea that it doesn't matter which of the two groups are exposed or not. Does that make sense? Any questions? Awesome. All right. I'm assuming you don't want to ask in front of everybody. I'll just wait for the break. Okay. Consistency is something that is a little bit more complex. It's the idea that a subject's counterfactual outcome under their under their observed exposure is their observed outcome. It's this idea that there is only one way of giving the exposure, of assigning exposure. That is, you're very clear or you have a very well-defined intervention. Okay, I'll explain this again in the next slides. We assume this is true. There is no way to test this at all. At least for exchangeability, you could just look at a table 1 in an article and kind of get at the idea, like, all right, the two groups look similar to each other. With consistency, you kind of have to take it on face value. It's like, yes, sure, we have consistency. But we can make sure of that by having a very well-defined exposure or intervention. Now, positivity. Positivity simply means that there is nobody in your study who has a 0 probability of being exposed. All right? There's nobody in your study who has no chance of being exposed to one of the two treatment arms. Let's just say you have a drug which is a teratogenic drug, cannot be given in pregnant women. Your study cannot include pregnant women or women who are planning to get pregnant. Right? And even if you're taking women of reproductive age, then you need to have certain additional caveats to including them, that they're willing to have at least 2 forms of contraception and so on. Right? Is this idea that there's nobody in this population who cannot either be assigned exposure or be assigned to not being exposed. Why is this important? It's important because when we get the final results of our study, we mean that result to be applicable to the entire population. If there is an actual group of people who under no circumstances will actually be exposed in the wild or in routine clinical practice, that's a problem because it doesn't apply to them. All right? So that's why positivity is important. The last one is model specification, and this is more so because of the fact that we no longer have like 10, 15 people in our study, or even 100, 200 people. Sometimes in RCTs, we have like very large number of individuals. We like to use statistical models to get to our answers, right? So your model has to be specified correctly. All of the things that you put in your model have to be specified correctly. And that's an entire art in itself. Is that okay? Thank you. All right. So if these assumptions are thought to be true, then the association that we're observing in an RCT is the average causal effect of the exposure on the outcome. That's what we believe going forward. Any questions? I think I shocked you a little, but you're okay. You're strong people. I got you. All right. So now let's leave the world of RCTs behind because that's not what we do. We do observational research, and that is exponentially more tough. Right? Because we don't have randomization. We don't have that. Nor do we have the money to do randomization, oftentimes at least. So what if you did not have resources to conduct an RCT? Even a small RCT conducted in a single center costs a lot of money. It has logistical challenges. You have to develop an infrastructure to do an RCT, which can be really challenging. So not every center can do that. However, routinely just like observing individuals sitting on the side and like looking at them, what are you doing? What are you not doing? Kind of people watching that you do in gardens, public gardens, that we can do, right? So observational studies are a lot more common because they are easier to do. They are cheaper to conduct. Oftentimes we have these large secondary healthcare databases that are already collecting the information for us. Kudos, awesome. done the job. I just need to analyze. Just need to analyze, right? Okay. So in this case, what I have is for this question, instead of an RCT, I have access to a real world healthcare database, either medical records or insurance claims, depending on what's your poison. And you decide to do a cohort study instead. The aim, I still want to know the average causal effect of the exposure and the outcome. That's not changed. That is still my research question. I just have to adapt it to the fact that in an observational study, when I'm not intervening on the exposure, I'm simply observing what's happening to people. Some people take the drug, some people don't take the drug, right? Now, in this case, in an observational study, where just, let's say, over the last 10 years, I've been able to accrue about like 5,000 people who take a drug, 5,000 people who either don't take the drug or take a comparator drug. All right, that's who I've been able to gather from the data. Do we have exchangeability of the two groups now? Do you think they are similar to each other in a way that an RCT randomizing 10,000 folks would be? Why not? You know the answer. Yes, right? So people take drugs for a reason. That reason could be what you would consider confounding by indication, right? Like if you're comparing a drug versus no drug, why would anybody take a drug? They're taking the drug because they have to take a drug. Nobody likes taking drugs, right? Medications are awful, especially if they come with like a schedule and it's so hard to take. So the idea behind it is the fact that that indication, the reason why you're taking a drug, would make the two groups very different from each other. Perhaps the reason why you need the drug is because you're older, you have more comorbidities, you have certain conditions that require you to take that drug, and that's why the two groups are not going to be exchangeable, mostly, right? So in this case, let's just say this is a DAG, which you'll come to, but let's just consider it a figure, just like you're doodling in your little notepad, and this is what you have. You have statin and you have AMI. The dashed line is simply because that's what I want to investigate. If it's a solid line, it simply means that yes, there is a relationship. Okay, so here I want to investigate whether taking statins has any benefits on heart attacks. Yes, that's a resounding yes. But let's just say it's about 10 years in the past and I'm looking at this question. Now, I want to look at statin versus no statin, right? Now, this is literally the least, the lowest, This is just me taking the most basic difference between the two groups. Because let's just say that those who are taking statins are older in age than those who don't take statins, okay? And those who are older also have a higher risk of having a heart attack. Now, this simply means that if you just look at the different ages in the two groups who are taking statins and not taking statins, one group is going to be older as compared to the other, right? So even if statins, in fact, don't have any causal effect on AMI, like that there's a null relationship, right? Whether you take statins or you don't take statins, it doesn't matter. You'll still have the same risk of having a heart attack. In the data, you will see that there's a positive relationship. That is, that those who take statins have a higher risk of having a heart attack compared to those who don't. That's got nothing to do with the drug in itself. It's simply because there are older folks who are taking statins. That's driving the outcome. All right? So that's the impact of confounding. You could see results that are not true. That's one of the biases. So in observational study, we often do not have exchangeability of exposed and unexposed groups just because of the presence of confounding. So at least at the most basic face value, we don't have exchangeability. And because of that, any association that I see, which is just a crude association, simply comparing those who are exposed versus not, without doing any additional fancy work, that is not going to be the true causal effect. That's just an association I see in the data. That could be driven by multiple different factors. Okay? So in this case, I do not have this exchangeability. The potential outcome, if everybody was exposed versus not, is not the observed outcome in the two exposed and unexposed groups. Is that all right? Okay. Does this mean that we can never estimate causal effects? I hope not, because that's kind of what we always do, right? So I'm going to say no. I'm being optimistic, but I'm going to say no, right? Under strong assumptions, we can estimate the causal effect. Careful design. So don't compare statins versus no statins. That's not a fair comparison, right? Maybe you could compare one statin versus another. You could compare statin versus another lipid-lowering drug. So there are some ways in managing the amount of confounding that's present, either in the design, measuring relevant variables of interest. So you could get a measurement of whether people have diabetes, hypertension, what's their blood levels of certain factors and all that. You could take a careful history of all the comorbid conditions that you think are important. And you would need to do appropriate statistical analyses to be able to estimate this average causal effect. So what do we need? We still have assumptions, but now it's all conditional assumptions, all right? So we have conditional exchangeability. It's the presence of confounding because it's a major issue. So we can no longer say that those who are exposed are exchangeable to those who are unexposed. But what we need is perhaps those who are exposed are exchangeable with those who are unexposed within strata of certain variables, right? So let's just say that within certain strata of age, sex, presence of diabetes, like history of diabetes, hypertension, within strata of certain cholesterol levels, now within each of these individual strata, now those who are getting statins and those who are not getting statins are going to be more comparable to each other, right? So it's our understanding that maybe we can get at conditional exchangeability. There's no real way to assess that. This is mostly done with respect to creating a list of variables that you think is important, looking in the literature, asking people who are a lot more experienced than you or experts in the substantive field who can give you more input on why the two groups are different from each other. Consistency is specifying a well-defined intervention. Now, I'll just explain what consistency means here, right? Is this idea of like, let's just say my exposure is, I want to compare those who lose 10% of their weight versus those who don't, okay? Now, there are different ways with respect to their improvement in cardiovascular health, perhaps blood pressure, let's just say that. That's my research question of interest. People can lose weight in multiple different ways. They could lose weight by simply dieting, by cutting their calories. They could do it by exercising. They could do a combination of the two. They could actually cut their calories so much that it's unhealthy for them, right? So there are multiple different ways. And this is what I mean when I say there are multiple versions of the exposure. There are multiple versions of the treatment, okay? So what a better research question would be that, how about I'm comparing those who lose 10% of their weight by exercising 5 times a day, at least 30 minutes, right? That's me defining my intervention really, really well. Like I want weight loss within a certain parameter. Like this is my definition of that. And you will notice that RCTs do a really good job at this. They make sure that the intervention is very well defined. If it's a drug versus no drug, the drug dose is specified. If there is a potential for dose escalation or like coming to a titration of the dose, that is specified. It's like, all right, some things are left to the physician's discretion, of course, depending on how well the patient responds. But that's the basic idea behind this, right? Conditional positivity, again, same idea, is just that there is no individual in your study who has has a zero probability of actually receiving one exposure versus another. Okay, so the most classic example is basically like pregnancy and teratogenicity. I feel like that really comes across very well, but also for like certain drugs that are contraindicated in certain conditions. Perhaps a drug cannot be given to anybody who has a GFR less than 30, right? So really severe renal disease, those people cannot be included in your study. And this is where careful design of the study can be really helpful. Make sure that everybody in your population is eligible for both of the two things. And correct model specification. Any questions? Okay, all right. So this is the introduction to causal inference, especially in the framework of counterfactual outcomes, right? So this is specifically the potential outcomes framework. You might have heard about causality being discussed in multiple different ways, right? One of the most common is the Bradford and Hill criteria. Everybody who's done an intro course of epi has learned these criteria because they've come from years of understanding what it means to say that something causes something else, especially in the era of smoking and lung cancer. It needed multiple iterations of the same kind of research question in different designs and different populations to be able to say that, yes, people accepted that, yes, cigarette smoking is bad, which we kind of know now, right? So it's the Bradford and Hill criteria, that criteria for causality, it doesn't usually depend on a single study. It's a collation. It's collating like multiple different sources to come to this conclusion because it has different criteria: temporality, strength of association, all of those things. You must also may have heard about the causal pi model, which was kind of I think developed by Ken Rothman, which comes into this idea of like what factors come together to cause the disease in a single person, right? There might be multiple different factors interacting with each other to cause a disease in a person. That might be different from the factors that are causing the diseases in another person. Let's just say lung cancer, for example. Somebody might develop lung cancer because they smoke a lot, they're older, and so on. Another person might develop lung cancer because they've got exposure to asbestos, and so on, right? So there are multiple different ways of getting to the outcome. And that's what the causal pi method does, is it kind of tries to define what are the different factors that could cause in connection to each other and whether there's an interaction. Is there a biological interaction in that causal mechanism? So the approach to causal inference in this session is mainly based on one research question in this one particular study. Can we estimate the causal effect by comparing the two groups, by making sure the assumptions are met? While the others are kind of collating more information out there in the literature to come to that conclusion, but they are all complementary to each other, right? We're still trying to get at the idea of whether an exposure is causing an outcome or not. Any questions so far? I know this was a lot. And please tell me if I'm too fast. I feel like I went maybe too fast. Okay. Take a break.
So I know some folks came in late because of difficulties with the shower at one of the hotels. So if you were impacted by that and missed sorry? Oh, it's a citywide. Oh my goodness. Okay, so be grateful if you took a shower this morning and you got it in. For anyone who was late and would like a very high level overview of what we covered up until the time you got here, why don't you come to the front of the room during the break and we'll do our best to give you those highlights. I also just emailed out the slides to everyone. If you didn't get them, let me know if you want them and didn't get them. I understand the slides are not yet available on the website, so hopefully you got them through email, so that way you can review what you may have missed, and also you can track along in the slides from here on out. But why don't we do a few minutes of questions, and then we can figure out how best to provide the highlights to those that missed that first part. Is it okay?
Sounds great. Questions? Anything? Basic? Yes.
Either covariates, confounders, effect modifiers, and what good resources are there to start thinking about causal inference in that setting?
That is such a good question. So the question is about certain fixed characteristics that individuals may have. So let's just say sex. We are trying to look at the causal effect of sex on an outcome. Sex is assigned at birth, right? Okay. And at that point, you are looking maybe 40, 50 years down the line to look at the outcome. Let's just say some type of cancer or some cardiovascular disease and so on. How can you truly estimate the causal effect of such conditions, right? And in this case, in this framework, it's really hard, right? Because this framework is centered around thinking about, hey, what if I did an RCT? What would that look like? You can't do an RCT with such, we could assign sex at birth. You could not randomize fetuses. At that point, it's already done, right? Everything is already assigned. We're already there. So in that case, what I would say is there have been a few articles that come at this question, because this is a question which rightly so, bothers a lot of social epidemiologists, because they want to look at the cause of certain characteristics over, like perhaps during their childhood, that might impact their outcome in adulthood. How do you do that kind of studies? Now, there has been a few good papers which have been co-written by Tyler Vanderveel and Nancy Krieger and Miguel Hernan. I think there was an entire section in Epidemiology Journal. I can look at that and send it out if anybody's interested. But the best case scenario in this case is the question in that case would not be a truly causal question under this framework. The only thing you could do is adjusting for everything else. Is there an association between sex and the outcome in that case? That's the only thing you can say under this particular framework. But there has been some work done to investigate this further. How do you bring about those questions, which are truly important questions and really impact the lives of individuals, but frame it in such a way that nobody can just say that, like, oh, it's just an association, it's not a causal effect, because that doesn't satisfy anybody. Because the whole point, like I said, of causal effects is to determine interventions, right? If you find out that high serum cholesterol causes you to develop cardiovascular disease, we intervene on that high serum cholesterol by giving them drugs, right? That's the idea behind thinking about causal effects. But yeah, I can send a few articles for that. Thank you for that question. Yes.
Thank you. One of the disadvantages of RCT is that we create a very ideal environment for the study by excluding those who are severely ill and contraindicated to take the drug and so on. So in observational studies, how we do the conditional positivity assumption, like by also excluding those who have severe situation and only have to take the drug, and so how we ensure that.
Great question, right? So one of the disadvantages of RCTs that I didn't really touch on too much was this idea of an RCT has an ideal population. There are healthy folks who are fine, even if it's a condition that requires, if you're trying to give a treatment which requires you to have diabetes or something like that, but you might not have any severe disease. They will not be having cancer. They will not be having any major infectious diseases, right? They perhaps have not already been diagnosed with a condition themselves or another cardiovascular condition. So the selection criteria for RCTs is usually very strict, because at that point, they're mainly concerned with showing that this drug has efficacy in a population who have the condition of interest or the indication. Obviously, like at that point in time, they may receive the approval in that case, but when the drug is actually marketed, it is given to older people. It is given to folks who have some sort of liver disease, if not like very, very severe liver disease and so on. So that is kind of what the observational studies do. They kind of expand to the population. The first step, anytime you're trying to look at the causal effect of an exposure and an outcome in an observational study, is perhaps to look at the descriptive of the folks who are receiving the drug in real life. Like in clinical practice, what is happening, right? Are individuals like this getting the drug, or is the prescription still being given to a very specific set of folks? And at that point, when you do discover that, like, okay, now the population who's receiving the drug is quite different than the population who had the RCT, which is most probably the case. Like, they don't market it to a very specific group of people anyways. In that case, you are more interested in looking at the causal effect in that broader population. You do have pragmatic trials, which kind of straddles the line between like strict RCTs and observational studies, where the selection criteria is a little bit more loose, but you still have randomization, the benefit of randomization, so that's done. But most of the times, you can still look at this group of people who are more broadly indicated in real life. And I think the post-marketing surveillance of the drug, even after it's being marketed, will help you understand a little bit more about the safety profile and if certain groups of individuals are more likely to get the disease, and perhaps there's a label change or something like that. So it's more so about kind of collating all the information up till that point, including phase 1, 2, 3 preclinical studies, to get at the idea of like in the label, all of that will be kind of given out is like, what are the contraindications?
So, what about the conditional positivity assumption in observational studies? So I think should we exclude those who have to take the drug, they have a probability of equal almost 1 to take the drug?
Yeah, at that point, you're kind of comparing apples to oranges, right? So let's just say there's a group of people, you're comparing two antihypertensive medications. And one of those medications is highly, highly preferred in folks who have diabetes. Now, in that case, it really depends on, is it like a deterministic thing? Like if you have diabetes, you are getting this drug, versus is it a more probabilistic thing? Like, all right, you have a 80% chance of like it's really beneficial, and that's kind of percolated into the population and the physician sphere, right? So you need to take a few more things into consideration, perhaps in that case, to really decide whether you do have that positivity. Now, in conditional positivity, very quickly, you do have something which is structured with non-positivity, which is what we're concerned about, versus random non-positivity, which is just a function of the number of people we have. If you're including 1,000 people in your study, you may just see in your data that, a specific age group, females who have a history of diabetes, who have history of hypertension, there's nobody who's exposed in your study. But that's a function of the fact that you have a small sample, right? There's nothing in the literature available that tells like these individuals cannot get. So that kind of structured non-positivity is what we're concerned with.
One last question, please. So for consistency also in the observational studies, so how we ensure that we have well-defined intervention?
Okay, this is going to sound awful. By having a well-defined intervention, that sounds bad. So the idea is like consistency is one of those things, like I mentioned, is something we assume to be true, or we assume that it holds, basically, right? This assumption. Because what it means when you don't have consistency is, let's just say you have aspirin, right? We have different doses of aspirin that often have different actions. All right. Now, if you just have an exposure of aspirin versus another antiplatelet, and you don't really specify the dose in your data when you're selecting folks who have aspirin, perhaps you've selected somebody who's taking a really high dose of aspirin who doesn't get that antiplatelet benefit, right? So it's simply a way of like ensuring that you do have a well-defined intervention from the get-go. There's a whole thing about like single unit treatment value assumption and all that stuff. Like that's there in the reading if you want to get into a little bit more, but it's definitely something. It's one of those assumptions which is just like, all right, let's make sure that we're defining our exposure to the best of our ability. Okay, thank you for all your questions.
Okay, so we're going to go into the break in just a moment. Before we do that, I understand that a few people are having problems downloading the file that I sent by email. Is everyone having that same problem? Okay, I'm going to attempt to send a link to a shared Dropbox file. So hopefully folks can access that on Dropbox. I'll do that in just a moment. If you continue to have trouble, let me know and we'll figure out another solution. But we'll go into the break now. Anyone who wants to get a high-level kind of primer on what we covered before you came in, feel free to migrate to the front of the room, and we'll reconvene in about 15 minutes.
Thank you so much.
Okay, we'll get going again in just a moment here. All right, welcome back. And for anyone who's either listening to the recording of this or who's at home live streaming, I hope you got your shower in this morning. Sounds like there's a water main break in the city here, and so it's been problematic for a lot of folks. But we're going to pick back up now. We're going to finish the first half of the session this morning talking about directed acyclic graphs. And I want to start out by talking about the what, the why, and the how of DAGs. So what is a DAG? Why do we use DAGs? And then how do we use them? And we're going to jump right in. Geeta introduced a simple DAG, and we're going to kind of revisit a version of that as we go through here this morning. And just to make sure everyone's awake, I've built in a whole bunch of pop quiz questions. So I'm going to be asking you a lot of questions as we go along to see if you're tracking and to make sure that we're reinforcing the concepts as we're progressing. So DAG is a directed acyclic graph. It's a graphical representation of a study. A DAG represents both variables, sometimes referred to as nodes or vertices of a study, and causal relations among those variables. So as Geeta pointed out, the arrows in a DAG represent causal associations or causal relations between two variables. And the solid line arrows that Geeta referred to means that at least one person in the population has that cause and effect relationship. So it doesn't need to be everyone, and usually it's not everyone, it's a subset. So returning to the simple DAG that Geeta showed, this is a DAG. In this case, it could be rosuvastatin versus no statin therapy causes Y. So it could be causing an increase in myocardial infarction, or in this case of rosuvastatin versus no treatment, it's probably reducing AMI. In both cases, that's represented whether it's an increase or a decrease by a solid arrow. Importantly, in a DAG, time flows from left to right. So it's directed in that way. So it's directed both in terms of the directionality of the causation, A to Y in this case, but also time is flowing in the left to right direction. So associations then flow in both directions. So we can say, in this case, A and Y are associated, right? It's the same thing to say Y and A are associated. But in this DAG, A causes Y, Y does not cause A. We refer to paths, and we'll come back to this concept as well. So path is just one way to get from one variable to another by traveling down the edges or down the arrows. And we refer to DAGs as acyclic because you can't get back to where you started by following causal arrows. That is to say, if time is flowing from left to right, you can't have both an arrow going from A to Y and then an arrow from Y going back to A, right? If you go from A to Y, Y can't now go back in time to cause A. There could be scenarios, and we'll look at one where A causes Y, and Y could cause subsequent exposure. So let's say that A is rosuvastatin, Y is heart attack or MI. The heart attack could determine whether or not you continue on rosuvastatin. So there could be another A after the Y, but Y can't go back to the original A. So why do we use DAGs? So DAGs are a really helpful tool for representing the study variables, but to guide the design of a study, to think about what data need to be collected, so what variables in a study to measure and potentially adjust for, and then to, of course, guide the analysis as well. We also use DAGs to communicate our study questions. So they're a nice graphical way to say, here's the question that I'm trying to study. And then in that question, we represent the associations that we're assuming or imposing on that study question. And in thinking through, and we'll get into the rules of DAGs, in thinking through the rules, it can help us determine or diagnose or detect whether there's biases that we may be introducing through either the design or the analysis of our study. Importantly, every research question has a separate DAG, so you need to customize your DAG for each specific study question, and you'll have an opportunity as we get into the activity later in the session to design your own DAG. Want to think through some of those concepts with you through a thought experiment. So suppose I give you this data set, a very simple data set with two variables. One variable is labeled rosuvastatin and one variable is labeled AMI. Based on the data in this table, and just assume that each of these 8 rows are individuals, so 8 individuals in the database, would you say that there's a statistical association between the rosuvastatin variable and the AMI variable? I see some nodding. And the answer is yes, right? So if you look at those that have rosuvastatin value 1, 3 out of 4 of those individuals have AMI 1, right? And so if you have rosuvastatin equals 1, you're more likely to have AMI equals 1 compared to people that have rosuvastatin equals 0. So there's an association. If you did your a risk ratio, it'd be 3 over 4 divided by 1 over 4, right? So it'd be a risk ratio of 3. Does this association represent a causal effect in this? So this is going back to kind of reinforce some of the concepts that Geeta introduced. Is this a causal association? I see some heads shaking. I see some of this, which you might not be able to see online. But yeah, the answer is we don't know, right? We need more information. We need to know a few things. So one is we don't know just based on this data set which came first, right? It could be the case that rosuvastatin could be causing AMI. It could also be the case that AMI is causing rosuvastatin. It could also be the case that there's some other variable that's causing both, right? Confounding, a common cause of both rosuvastatin and AMI. And then relatedly, is there enough information? Have I given you enough information to draw a DAG representing a study question based on these data? No, right? So we don't know, again, we don't know which came first. We wouldn't know which arrows to draw in which direction. We don't know whether there are those confounders that we'd also like to represent in our DAG. So as we saw in the first slide, there's at least one way to represent how variables are related in a DAG using direct arrows from A to Y. So in this case, as we said, this is representing A causes Y. We can also represent Y causing A rather here on the right. But there's a couple of other ways within a DAG that variables can be associated. So one is through confounding, and we're going to go through each of these in more detail. So this is sort of a little bit of a teaser in terms of what we're going to go through from here on out. But confounding, as Geeta described, and as many of you probably know already, is a common cause of two other variables. So in this DAG in the middle of the slide, A does not cause Y, nor does Y cause A, but A and Y are associated, right? So if you think about the rosuvastatin example, it may be that people, when compared to no treatment, people who get rosuvastatin have higher cholesterol, right? You're more likely to be treated if you have high cholesterol. High cholesterol may also be causing heart attack. And so in your data, in that table that we saw, people who get rosuvastatin may be more likely to get AMI due to that confounding, even in the absence of a causal effect. So there's no arrow here between A and Y. There's another slightly more complex way in which variables can be related, and this is what we refer to as conditioning on a collider. And we'll go into this in more detail, so don't worry if this doesn't make sense just yet. But a collider, very briefly, is a variable where two or more arrows go into it. So they collide on that variable. So in this case, this variable S is a collider because you have arrows from A into S and also from Y into S. And as we'll discuss, if you condition on S, which in a DAG is putting a box around it, it actually creates this association between A and Y. So we're going to pin that for now. We're going to come back to it, but I just wanted to at least lay out the three different ways that variables can be associated. All right, so here's our first pop quiz. The question, so take a moment to look at the DAG or the diagram. And the question is this a DAG? How many say this is a DAG? How many say this is not a DAG? All right, so for those who can't see the folks in the room, it was unanimous. This is not a DAG. Can someone just call out why this is not a DAG? It's cyclic, right? So you can go from L to Y and then back to L. So you have a time machine that takes you back in time, which is exactly what you'd want for the counterfactual, right? You'd want to take each individual, expose them, put them in a time machine, bring them back so you can observe their counterfactual outcome under no treatment. But unfortunately, we don't yet have time machines. All right, pop quiz number 2. And this is a slightly different diagram. How many paths are there between L and Y in this DAG? 2. Good, I heard 2 from a few people. So you have a direct path, right? You have a direct, in this case, causal relation between L and Y. L causes Y, because we've got a solid arrow here. But you've also got a path between L and Y through A, right? So in this case, A is something of a causal intermediate. It's in this, if we're thinking about a rosuvastatin example, it may be that L is causing treatment. So it might be LDL, high LDL is causing treatment with rosuvastatin. And then that's having an impact, maybe a protective effect on the outcome. So L can be both increasing your outcome, and it can also be decreasing it by increasing the probability that you get A, which then decreases your risk, right? So there's a few different ways. And importantly, in this, in a DAG like this, there may be many other intermediate variables. So for example, and Stan and I were having a conversation about this just at the break, there may be a whole bunch of ways, different mechanisms in which A could impact Y. So it might be reduction in cholesterol, it might be reduction in CRP. The DAGs don't tell you about those specific mechanisms. And for the purposes of drawing a DAG, we don't usually represent all of the intermediates unless there's a specific reason to do so, because we are conditioning on it or because we think there may be other potential biases that we want to reflect in our DAG. So there's a lot kind of going on behind the scenes. The DAG is just a very high level representation of a conceptual model for our study. Okay, the third pop quiz here on this slide is how many paths there are between A and Y in this DAG. So how many ways in which A and Y are associated? So there's one direct path, right? So A causes Y, but because of the confounding, there's actually also another way in which A and Y are associated, right? And that's through L. So L is causing both. So if we go back to this slide, the LDL might be causing A and Y, so it's associated via that path. And it might be, as we said, that L is causing Y, increasing Y via this path, and decreasing Y via this path. So the direction of those associations may be different, right? And so as drawn, the DAG doesn't give you any indication of which direction the effects are going. So confounding, as we talked about, I'm going to repeat some of what we've mentioned already, induces a statistical but not a causal association, right? So even under the null hypothesis, even in the absence of a causal effect between A and Y, they can be associated by the confounder, so by going through L. And just to revisit this example, and I'm going to bring back the data that we saw in just a moment. So in this case, cholesterol or LDL cholesterol may be increasing rosuvastatin and increasing AMI, creating an association. And that might, in our data, look like something like this, where, again, we've got the same 8 individuals, half of whom are exposed to rosuvastatin, half of whom are not. We've got 4 individuals who had the outcome of AMI. And for simplicity, what I did is created this third variable, which could be LDL. And I said for everyone who's got, and there's 2 values of LDL in this world, 200 and 100, everyone who's got a value of 200 gets AMI, and everyone who has a value of 100 does not. And what you can see is if you do some simple stratification mentally, and you analyze just those people in the 200 LDL stratum, you've got 3 people exposed to rosuvastatin, they all have AMI. You've got 1 person unexposed, they have AMI. And so within that stratum, there's no association between rosuvastatin and AMI. And similarly, in the stratum of LDL equals 100, you've got 1 exposed person, 3 unexposed people, no one has the outcome. So now you can see sort of in numbers how this confounding induces that statistical association, but then when you condition on L, so you adjust for cholesterol in your design or analysis, that association goes away. So now you get to the true representation of a causal effect of this case, in this case of no effect in this hypothetical example of rosuvastatin on AMI. Does this all make sense so far? Any questions? Okay. So as I mentioned before, the way we represent that conditioning in the case of the example we just used where we stratify it, so stratification is a form of conditioning, we put a box around cholesterol, around the confounder. And now, and we'll get into the rules of DAGs, now when we look at this DAG, there's no longer a way to get from rosuvastatin to AMI. The conditioning, this box around the confounder, blocks that path. And so you can no longer travel between rosuvastatin and AMI. And so that's graphically how we represent conditional adjustment, whether it's stratification, whether it's including a cholesterol or a confounder as an independent variable in an outcome model, whether it's matching, for example, by propensity score, whether it's a form of restriction. Those are all conditional approaches to dealing with confounding that we represent using a box. One exception is weighting, and we're not going to get into weighting, but in theory, what weighting does is rather than putting a box around cholesterol, it actually removes the arrow between cholesterol and rosuvastatin. So that's a slightly more advanced topic that we won't get into, but just worthwhile kind of pinning that weighting is a slightly different approach than conditioning as we think through DAGs. Okay, 2 more pop quizzes. So here's another DAG, looks familiar. Is there a statistical association between A and Y in this DAG? How many yeses? Statistical association between A and Y. How many no's? So a lot of no votes. So there were a few hands for yes. I didn't see any for no. The answer is yes, right? So there's a statistical association between A and Y. This matches the data in the table we saw, where A and Y are associated in those data, but they're not causally related, right? It was cholesterol, LDL cholesterol causing both, a common cause of both, that was inducing that statistical association. And I think I just gave away the answer. Is there a causal relation between A and Y in this DAG? No, right? We don't have an arrow, a direct arrow between A and Y. Is there a statistical association between A and Y in this DAG? Yes. So one thing I should point out that a statistical association, a causal association is also a statistical association, but a statistical association is not necessarily a causal association. So because I'm going to give you the answer to the second question, because there is a causal relation between A and Y, there's also a statistical association between them in this DAG. All right, question 8. Is there a statistical association between A and Y in this DAG? Yes. Is there a causal association between A and Y in this DAG? Yes, good. So there's both a causal association, and that's also a statistical association, but there's also the second pathway of a statistical association through the confounding by L, right? All right, and 2 more for now. So question 10 is there a statistical association between A and Y in this DAG? I see mostly heads shaking. Can someone who's shaking their head call out Y? We've blocked it, right? So we've conditioned on L. So this represents the world in which we've adjusted for L by matching stratification, outcome adjustment, outcome regression. In doing so, it blocks that confounding by L. So you can no longer get from A to Y, you no longer have that statistical association. And I think you'll all appreciate now there's no causal relation between A and Y as a result of not having an arrow between them. All right, so the rules of DAGs, or deseparation, as I've alluded to a couple of times already, are a set of sort of formalized way to approach DAGs to think through how these variables are related. And we've sort of covered them already, but I want to formalize it in terms of the deseparation rules a little bit. D in this case stands for direction, and we use the deseparation to decide whether, just as we did, variables such as A and Y are independent of each other, so not associated either causally or statistically, including whether they're independent given another variable, so conditional on another variable. So in this case, A and Y, we would say, are independent of each other, conditional on L, right? We've conditioned on this. But if we didn't condition on L, so we didn't have a box around it, we didn't adjust for cholesterol, A and Y would be statistically associated. They would not be independent. All right. And so these rules, as I think we've seen so far, are helpful in deciding which paths are non-causal and causing confounding that we need to block, just like we did with L. And then they're useful for checking the presence of open paths that we may not have thought to adjust for in some form that could be causing bias. Or, as we'll talk about with the conditioning on a collider, it's also useful for detecting whether we've conditioned on a variable that may be introducing some what we might call a backdoor path between variables by that conditioning on a collider. Okay, so the first rule is if there are no variables being conditioned on, no boxes, no adjustment, a path is blocked if and only if two arrowheads collide at some point on that path. So that's colliding on that same variable. And you can see that here. So the path between A and Y, so let's say this path between L and A is blocked by conditioning on Y, right? So by colliding on Y. So you can go from A to Y through the confounding path, but you can't go from L to A via this path because the two arrowheads collide on Y. This DAG's probably a little bit more complicated than we need it to be. So imagine that there's no L to A arrow there. So A and Y would represent a causal association. L would be causing Y, but there'd be no statistical association without this arrow from L to A between L and A, right? They're independent risk factors for Y, for the outcome. Is that okay? The second rule is any path that contains a non-collider, so non-collider is any variable that doesn't have at least two arrowheads going into it, that has been conditioned on, so non-collider that has been conditioned on is blocked, right? And that was our confounding example. So just I'm gonna skip ahead here. So on the right, that's our confounding example. This path between A and Y had been opened by this confounding by L, but we've blocked it. But this rule is also helpful in thinking through what happens when we condition on an intermediate. So a potential downstream consequence of our exposure that may be on the causal pathway. So take this example here, and maybe this is our rosuvastatin example again, where we've got rosuvastatin versus nothing. That's our A variable. We've got our outcome Y of heart attack or myocardial infarction. We've got confounding by baseline LDL. So this is LDL measured before people start follow-up. And then we may also have a measure of LDL in follow-up, right? So maybe we're examining not only whether rosuvastatin causes the outcome of AMI, but we're also examining to what extent rosuvastatin is lowering LDL. So we do those measurements in follow-up. And in this DAG, if we condition on L, we can recover a causal estimate, right? So if we condition on L, deal with the confounding, so block out L, you can still see that causal path between A and Y. It goes through I in this case, but there's still that causal path there. But let's imagine that you condition on I. And what the second D separation rule says is, again, is that any path that contains a non-collider, I is a non-collider, that has been conditioned on blocks that path. So now you can no longer get from A to Y via this causal path. You've adjusted for that intermediate value of LDL in follow-up. And this is why we say when you adjust for downstream consequences or something on the causal pathway, you can no longer observe the true effect or the true causal relation between A and Y. So we've blocked that path. So imagine that this is LDL measured during follow-up. And let's imagine that some people respond, that is, their LDL comes down, and some people don't. If you stratify those groups based on that intermediate value of LDL and look within those two strata of people that respond and don't, you'll see no effect, right? Within the strata of people who responded, everyone's responded, and that obscures the ability to estimate that causal effect between A and Y. And if no one responds in the other stratum, then there is no causal effect because A would be having no impact on Y, so it's not reducing LDL. There could again be other pathways, right? So this is a DAG representing the worldview that there's only one path between rosuvastatin exposure and the outcome AMI, in this case through LDL lowering. But again, there could be other pathways that we're not considering here. So it could still, even if you conditioned on LDL lowering, that could be that maybe there's an effect on CRP that's having an impact on AMI. This is also where, as I mentioned, the weighting approaches become very useful. So in theory, what you'd want to do, if you were trying to isolate a specific mechanistic pathway, so if you wanted to know, independent of rosuvastatin's ability to lower LDL, is there a causal effect of rosuvastatin on outcome through some other pathway? You one idea would be you'd want to condition on this. There's reasons that you don't want to do that, which is that you could be opening up other pathways that are not represented in this DAG. But the sort of theoretically sound approach would be to use a weighting approach that would remove the arrow, so you would no longer be conditioning and opening up other paths, but it'd enable you to see a different pathway between A and Y. So that's, again, going a little bit more advanced than what we want to cover in this course, but just wanted to put it out there in case anyone wants to bite on it in terms of questions later. The third rule is that, and we talked about this a little bit already, a collider, so again, a variable that has at least 2 arrowheads coming into it, a collider that has been conditioned on does not block a path. So whereas a collider that's not conditioned on is blocking the path, once you adjust for that variable, you condition on it, it's now opening up a path. And this is what we refer to in EPI as selection bias. So I'm going to try to explain this example. So imagine we're doing a case control study. And our question again is, does rosuvastatin A cause heart attack Y? And we are identifying individuals based on their outcome. So we want to identify everyone in our study population that has the outcome of heart attack. And now we're going to select a sample, just a subset of the controls, a subset of the people that don't have heart attack. And let's imagine that we're not only selecting a sample of those controls, but we're selecting them in a way that they're matched on LDL value to the cases. So what we've done is, by selecting a subset of the cases, we have restricted the population, right? The restriction is a form of conditioning. So we've put a box around S. And there's an arrow going into S because our selection of the controls now depends on their LDL value because we're matching them. So we're getting not only a subset of the controls, but we're getting just that subset that have values of LDL that match the values of the cases. And so now we've got a scenario where we have a collider selection that depends on LDL, it depends on the outcome, and we've conditioned on it via that restriction, via that selection of the controls. And so we've now opened up this path. We put a box around selection. We've opened up this path, and now there's, even though there's no confounding in this DAG, so there's no direct effect of L on Y, so L doesn't cause Y, even though there's no confounding, we've introduced the bias. You can now get from Y through S, having conditioned on that collider, to A, right? So L's effectively a confounder of the AS association, and so you can move through that node here. And so this is why in a case control study, matching in and of itself doesn't address confounding. This is why in a case control study with matching, you still have to do a conditional analysis. What the conditional analysis is doing is it's putting a box around L, right? So there's a couple of ways to do it. You could adjust for L in your outcome model, or you can condition on the match set in the analytic step, in the analysis via, let's say, a conditional logistic regression model. And what that conditioning is doing is putting a box around L, right? So we've actually, by creating the sampling process, induced a bias that we then have to resolve through our analysis by doing a conditional analysis. Okay. Any questions? And then related to that last point, and this one's sort of minor, but in the case where you do have a collider, if it's got a descendant, so descendant is any variable that comes after. So in this case, C is a descendant of S. S causes C, so C is a descendant of S. Even though we haven't conditioned on S in this DAG, we've conditioned on C, and that's basically the same thing as conditioning on S. So even though we haven't formally conditioned on S, we've conditioned on C, and that too opens up this path by proxy. And so there's ways to represent proxy variables in DAG. So C you can think of as a proxy for S, and if you condition on that proxy, it's effectively the same as conditioning on S here, which is when we think about confounding, and we think about if we're using a secondary database where we don't have all the perfect measures of every variable that we'd want to adjust for. It's why proxy adjustment can be helpful. So you may not have L. L may be cholesterol value, might be your actual LDL cholesterol, but in our data, if we're using an administrative claims database, for example, you might only have a diagnosis code of hyperlipidemia. And so adjusting for that code is a proxy for LDL. So it'll adjust in part for L, but not in full. So L would be actually causing whether you get that diagnosis code of hypercholesterolemia and you adjust for it. It's not quite as good as adjusting for L, but it will partially block that path. Okay, I have one more pop quiz, then we have plenty of time for questions for this session. So question 12, is there a statistical association between A and Y in this DAG? See at least one head nodding and one head shaking. Okay, a couple of heads shaking. So is there a statistical association between A and Y in this DAG? So you've conditioned on L, right? And by conditioning on L, even though C is the cause of Y, conditioning on L blocks that path between A and C, right? So it's blocked that confounding path. So without conditioning on L, we could go from A to L to C to Y, but this path is blocked, even though it's not conditioning on C itself. Okay, and then finally, is there a causal relation between A and Y in this DAG? No. Okay, good. All right, so that was a lot to cover in a fairly short amount of time. What questions do you have? All right, let's start here in the back. Yep.
So I have a question. So how are we going to represent reverse causality in a DAG?
Yeah,
if we say that the arrow has to come from the left to the right?
That's this right here, right? So reverse causality could be a couple of things. So let me unpack it a little bit. So reverse causality could be that A is actually causing Y. So maybe you've got people who've had heart attack, and then your A variable is actually whether or not you get subsequent treatment. So in that case, A may actually be causing Y. There's also sort of this more nuanced way of thinking about reverse causation, and I'll use this middle DAG with confounding, where reverse causation can be a form of confounding. So let's imagine that we have, I'm trying to think of a good example on the fly, but this will be a little bit clunky, but bear with me. So we've got an exposure A, and let's imagine that that we have a variable that is causing A. So so maybe I'll try to make this work with the AMI example. So people will often be put on a statin after they've had AMI. So that's sort of secondary prevention versus primary prevention, where they have high cholesterol, have not yet had a heart attack, and are put on a statin. So let's imagine a weird scenario where someone's had a heart attack, they get put on AMI, but we don't actually know that they had a heart attack, right? So maybe for some reason we don't observe it in the data. The heart attack is a risk factor for a subsequent heart attack. And what we measure is some measure of that subsequent heart attack, or maybe it's something about the coding in the data that's picking up the code for the heart attack late. And in that case, in the data, it might look like A is coming before Y, because Y is just some imperfect measure of the prior heart attack. And it would look like, in that case, A is causing Y, when in fact, it may have been that there was a prior heart attack that we don't have a good measure of that was causing A. I don't know, Geeta, if you can think of a more intuitive example than that, but I don't mean to put you on the spot.
No, I think that's a good question. With reverse causality, so most of the times when we think about reverse causality, we're thinking about falsely assuming A causes Y when it's the other way around. Y is causing A, right? And that is oftentimes seen in study designs which measure both A and Y at the same time. So you may have a cross-sectional study where you're gathering information from individuals, you're gathering information on whether they are on statins right now and whether they've had a heart attack. You're collecting both information at the same time, right? Now your assumption is that every one of those individuals who is exposed is taking statins and has had a heart attack, the arrow goes from A to Y. But that's not true. In the data, like in real life, it just could be that like there were lots of people who were not taking statins till they had the heart attack. And only after they had a heart attack, they started taking statins. But in my data, I'm going to see that association of A and Y, even though the directionality is in the other way around. So the first thing that I would say is when you're drawing a DAG, that is your representation of how you think things are going to happen. And you're going to best use that information to design your study. Now, one way to do that potentially could be ask, if you're doing a cross-sectional study, let's just say, ask if you could access their medical records so that you could get actual times at which exposure and outcome happened, right? Because remember, temporality is one of the absolutes for causal effect. Your exposure should precede your outcome. Your exposure cannot happen after the outcome. Otherwise, how can it cause the outcome, right? So I feel like it's going to be in your DAG, that might be the way that you're thinking the relationship is going to be, but just by the way of your study design, the data that you have does not adequately reflect what's happening in your DAG. So in that case, I think it's going to be more on you as a researcher to kind of make sure that you do have clear temporal relationships established in your data. And in that way, that's the best way to kind of remove that. But Josh mentioned that, like, that's where you could have statin use month 1, month 2, month 3, month 4. Right now, for ease, we just have one exposure. We're assuming that exposure happened at a time and that's causing the outcome. But you could expand the simple DAG into including time points as well. Start of the study, 3 months in, are they still exposed? 6 months in, are they still exposed? 9 months in, are they still exposed, right? So you could make it a little bit more complex. But right now, simplest case example, like, see what the DAG is. You are drawing the DAG when you're conceptualizing the study. It's a great way to make sure. The reason why we kind of put in, like, there are multiple different ways A and Y, which are the exposure and the outcome, are associated in the data, is so that we could eliminate anything that is not causal, right? You have confounding, account for that in the analysis or the design. You have selection bias, make sure you're accounting for that in the analysis. So that's our way of making sure that any remaining association that you see in your study is just whatever is left over, which is the causal effect. Because I've already drawn my DAG in such a fashion that I'm able to identify all confounders, all confounding pathways, as well as any selection bias pathways, even before starting the study, right? I've already conceptualized it. I know what information to collect, and I know how to actually analyze the study. Yeah. So that in the end, what's left over is causal effect. It's kind of like exclusion to everything else, because it's not possible for you to kind of show that A causes Y immediately just like that.
Yeah, and thanks, Keith. That's a great answer. And I think it also gave me a little bit of space to think about another intuitive example. So just return to this middle DAG for a moment. Let's imagine that, getting away from our statin example, we're interested in knowing whether drug A causes stomach cancer. And let's imagine that we have various measures in our data. So we can measure whether people get drug A. And it might be that, in this case, early symptoms of the stomach cancer could be causing someone to get treatment, right? And so the early symptoms might be L. We may or may not be able to identify those in whatever data source we're using. And Y might be clinically diagnosed, later stage stomach cancer, right? And so in this case, we're interested in whether A causes stomach cancer. We have two measures of stomach cancer. We have this early stage that is preclinical, and we have this later clinical stage cancer. And it might look something like this, where the early stage cancer is causing the exposure. It's also, those who have early stage go on to late stage. So you've got this arrow from L to Y. And so it's a confounding problem that then in your data, because you might just look at A and Y, manifests as a reverse causality problem because of the different measurements, as Geeta was saying. Great question. There's another question over here.
You've talked about confounding, like using DAGs to represent confounding and selection bias. I wonder if they could also be used for information bias.
Yeah, that's a great point. And we don't cover it here, but the answer is yes. And so the way that you might think about measurement bias, so a mismeasured variable could be represented on a DAG almost in the same way as I described the proxy variables. So let's imagine that, using confounder misclassification as an example, let's imagine that this is our DAG. We really need to know LDL to fully adjust for the confounding that's happening here, as patients are being prescribed rosuvastatin due to their cholesterol, but we may not have that good measurement of LDL. We might have just some indicator that they have high cholesterol or low cholesterol. So that measured variable of whether they have high or low cholesterol is a mismeasured version, essentially, of the actual underlying LDL, right? And so what you do graphically is you'd have a variable that is a descendant of L, right? L, the actual LDL value, is causing whether you get a diagnosis of high cholesterol, for example, or some indicator in the data. And so you'd have like an L star or an L prime up here. And then what you're adjusting for in the data is the L prime rather than this L. So you'd be conditioning on that L. And it would, by proxy, then be adjusting for the L. So that's sort of information bias when the misclassification is due to the confounder, but you can sort of expand that to think about an exposure in the same way and an outcome in the same way. Yeah, one more question in the back, and then we'll take a break, and we have more time for questions during the break.
So we have quite a few people who will be, say, on a statin, get an MI, but they have the pre-existing condition of diabetes. So you've got an effect modifier and then kind of acts like a confounder, right, to that outcome. How would you draw that in a DAG?
Yeah, this is going to be up to you to do in the activity. And so that's actually a good segue into the activity, because that's exactly what we're going to be asking you to do. So I don't want to give away the answer. We can work through that together when we get there, but that's exactly where we're going. So thanks for that leeway. Okay, let's take a break. We're going to do, let's do a 10-minute break since we took 15 before, just to stand up, walk around, refresh your coffee, water, bio break, and then let's restart. I guess we'll do 12 minutes. Let's restart at 10:45 local time. So before Geeta gets started, I just wanted to clarify, there were two really good questions that came up during the break. And the first one relates to sort of a subtle point that I definitely did not make clearly enough, which is that when we think about causality, the arrows represent the direction of causality. So in this case, L is causing A and A is causing Y, but association works in both directions. And so L causes A does not cause Y, but the association between L and A runs both ways. So if you think about, without making this too complicated, if you think about this example where we didn't know what comes first, we didn't know whether rosuvastatin causes AMI or vice versa, the association works both ways. If you said, okay, I think rosuvastatin's the exposure, I'm going to estimate my risk ratio of the effect of rosuvastatin on AMI, you get 3. But if you flipped it around, you said, no, I think in this case, AMI is the exposure and rosuvastatin is the outcome, you can also observe an association when you do that risk ratio, right? So that association is going in both directions, regardless of which variable you think of as sort of the exposure, or regardless of which one is causing the other one. But the causality runs in only one direction. That's why when we look at this confounding DAG, you can go from A to L to Y, right? So you don't need to follow the direction of the arrow. You're following the direction of association. And in this case, association is running both ways here. So hopefully that helps clarify one thing. The other really good question that came up is around matching in both a case control study and a cohort study. So the selection bias example that we talked about is specific in this case to a case control study, where matching in and of itself is not fully addressing the confounding by L. It's actually introducing this backdoor path that we described. And that's different from matching in a cohort study. So if you get a group of exposed people and a group of unexposed people, you match them exactly on LDL. Those two groups, just like in the randomized trial that Geeta described, those two groups then have exactly the same average baseline LDL values. And just like in the randomized trial, you don't actually need to adjust for the LDL value in that cohort context, but it's an important difference between case control and cohort studies. So hopefully that was more clarifying than confusing. And without further ado, we're going to go into the target trial framework, which Geeta is going to walk us through.
Thanks, Josh. very quick note on the association versus causation. I find that the best way to think about association is, if you know something about A, does it tell you whether the same person is more likely or less likely to have Y, right? So in the rosuvastatin example, if you know that a person is taking rosuvastatin, you have an idea from the data that they're more likely to have AMI, right? But if you know a person's AMI status, like, all right, this person did not have AMI, he's free from myocardial infarction, then you have an idea that yes, they are less likely to have taken rosuvastatin, right? So that's why association goes in both directions. Rosuvastatin is associated with AMI, AMI is associated with rosuvastatin. There's no directionality there. Causation is about directionalities, like, does giving somebody rosuvastatin increase their risk of having myocardial infarction or not, right? That is what is meant by causation. You're intervening on the exposure to cause the outcome. I hope that clarifies things a little bit more. Okay, so we're going to start on the target trial framework. So one question that might be entering your mind would be, why in a course titled Foundations of Causal Inference are we talking about target trial framework? This is simply because just talking about causal inference in a vacuum is not really going to help you understand how to apply those principles, right? So we've taken the principle of using, or especially a framework that is the target trial framework, to kind of hit home all the points that we want to mention about the causal inference. Using the target trial framework makes everything more explicit. So this is not to say that before this particular framework was introduced explicitly, or the way that it is being used currently, that folks didn't have any idea about how to use RCTs to inform observational study design. We've been doing that for ages, right? That's not really changed. Anytime you think about you're starting to design an observational study in your life so far, you've always kind of been thinking about, like, all right, there's an RCT published, this is the kind of population that they're using, this is the design that I think would best reflect what I'm looking for, right? We're always thinking in terms of how to best mimic or emulate a trial. The target trial framework simply makes all of the decisions that we're making extremely explicit by creating a table about it, all right? So target trial framework is just another way of being explicit and transparent with designing and analyzing observational studies. The idea is to first, before we design an observational study, let's, in our minds, design a trial, right? If I wanted to do this research question, if I wanted to answer a particular research question, how would I go about designing a trial that I want to be, include as many folks as possible, not be very restrictive? So in our minds, we are almost designing a pragmatic trial. What would that best look like using the kind of data that we are going to use in observational studies? So that's the question, that's the first step to actually using the target trial framework. Specify the trial. Specify how you would include people. What is the selection criteria? Specify what the treatments that you're going to compare are. What are the treatment strategies? How are you going to randomize folks? How are you going to follow individuals up? How are you going to identify them for their outcomes? How are you going to analyze them? All of these steps first need to be specified for the trial. Then, with the data that you have, you will start to see, like, how can I best emulate these selection criteria using the observational data that I have. Okay, so I'll just take you through those steps, and then we'll have plenty of time because we have a case example, and we would like you to think through some of these components. What are the challenges in specifying each of these components and so on? We can discuss that a little bit more. Okay. So, like I said, identify, first of all, usually, I know they say that you should have a research question first, and then depending on what components you have, you would go about choosing the right database, but that's not, we don't always have the luxury of that, which is why I kind of put step 0 as, hey, just check what kind of data do you have, right? So in this case, maybe you do have a choice of different databases, which is great. Then you can start specifying the target trial, and when you're emulating the observational studies, you could go about like, all right, I think this database is the best suited one for that, right? So you usually have a good sense of what kind of data you need, depending on what your research question is. Then you have the specification of the trial, followed by specifying the protocol of the observational study. Obviously, then you actually have to do the study, right? So once you are able to identify where and how the trial and the observational study deviate from each other, that's a great way of catching any biases that you may not have thought of. So step 0, I'm not going to spend a lot of time on this because I know I think there've already been sessions about different databases in pharmacoepi studies. I just wanted to bring your attention to, depending on the research question that you're interested in, you might want one kind of data more than the others, right? So when we are using in pharmacoepi studies, mostly healthcare data, oftentimes secondary healthcare databases, which just means that the data has already been collected, ready for you to use. When I say ready, not really ready, but there's data, right? It's messy, it's crazy, you don't know who are included, sure, but it's data available, compared to a primary data collection where you'll probably be designing the study and the data form and everything for ages before actually starting to do the study, which would itself take a long amount of time, wait for the outcomes to happen and so on. So primary data collection, while great, is also really hard and challenging to do. So a lot of times in pharmacoepi studies, we have these large healthcare databases that oftentimes we do have access to. We're trying to leverage it, right? So in that case, we need to understand what is available in the data. Is it on a patient level? Is it on an encounter level? Is it collected from hospitals? Is it collected from outpatient departments? Is it collected from emergency departments? Is it actually just insurance claims? Like anything that a physician or the healthcare provider is billing for is available to you. In that case, you need to think not just about the kind of data you have, but also the kind of data you don't have, right? If you're thinking about billing data, you don't have access to over-the-counter medications. You don't have access to people who don't have insurance, right? That's a big subgroup of people who you might really be interested in. In that case, that's not a good source of data for you to use. So depending on what you want in your study and the population you want, you might have to figure out which database to best use. Okay. One quick note, I'll just point this here, is simply because insurance claims, remember, it'll have this idea, you will see a code like, hey, USG was done, ultrasonograph was done, LDL levels were done, test was conducted. You don't see the results of that test, right? So that's also a really critical thing to keep in mind. Sometimes the physician just ordering a test tells us something about the probability that the patient has the condition in itself, right? But if it's just a follow-up thing, like everybody gets a blood sugar level when they have a diagnosis of diabetes, that doesn't really tell you whether the blood levels were high, low, normal, whatever, okay? So just keep this in mind whenever you're designing a study yourself. All right, so let's come to the specification of the trial. Now, in a trial or in the observational data, there are certain components that we need to mention. First one is, who are we going to include in our study? Who are eligible for the trial, right? In a trial, what is a luxury that we have? We have the luxury of prospectively screening folks and bringing them in. If I want to conduct a trial, even if it's a pragmatic trial, oftentimes I can actually be like, all right, I want your lifetime history of whether you had a heart attack or not, or a lifetime history of whether you had a stroke or not. You can ask the patient, you can request their medical records. You could do all of these to make sure that this individual has never had a stroke, right? But in observational studies, that might not always be the case. So in trials, that's one of the first things that's going to be different between your trial and your observational study, is just how well are you able to assess your eligibility criteria. Then the treatment strategies. Here's where it's important to be very specific about the treatments that you're going to compare. If you're comparing statins, what dose statins are you thinking? Are you thinking high intensity statins, low intensity statins, medium intensity statins, or does that not matter, right? Because oftentimes, like the physicians might be interested in just titrating the dose depending on what's the best available benefit to the individual. So all of those things have to be mentioned in the treatment strategies. What is the assignment procedure? Assignment procedure simply in a trial is the act of randomization, right? So at what point do you randomize folks? Once their screening is complete, do you want a washout period? Do you not want a washout period? What are you thinking about? Then once the treatment assignment has been decided, then it's follow-up and outcomes. The follow-up for a target trial, like I mentioned, we try to be as pragmatic as possible, because if you're being too strict, there is no way that an observational study can do what you need to like emulate. So in pragmatic trials, like in usually stricter trials, what you have is a patient is supposed to come in every 3 months, every 6 months, perhaps every month for the first 6 months or so. So there's a lot of investment of time that a patient has to give, as well as a physician has to, like all the providers have to give, right? So you might want to relax it a little bit in a pragmatic trial, because a pragmatic trial is one that is conducted in a routine healthcare setting. So you ask the patient like, hey, I'd like for you to come every 3 months just to make sure that we are on the right path. And that's, I think, also routine for just general healthcare practice. Not all of us go every 3 months, though. I know I did. Right? So it's this idea of like, what is the follow-up time that's important? The outcome, how are you going to measure the outcome? Are you going to do tests to make sure that the outcome is present? For example, cancer, right? You might, before a person is diagnosed as having cancer, they have to go probably multiple steps to make sure that there's exclusion, what are the causes, somebody's developing these symptoms, and so on. It's not just one day they come up and it's like, all right, this person is diagnosed with cancer. But in the data, that's what I'm going to see. I'm not going to be able to see all the process that is happening, like clinical process that's happening during the time period. So you need to mention how the outcome is going to be assessed. That's, again, a benefit of the trial, that oftentimes in actual like trials, outcomes are adjudicated. So they collect all the information, they kind of have a provisional diagnosis. You have a panel of physicians, a panel of experts who decide whether, yes, this is a definite diagnosis versus a probable diagnosis versus the patient does not have the outcome. So all of that stuff is consistently being done. Then we have the causal contrast of interest and the statistical analysis plan. I'll go through these a little bit more as we proceed. Okay, is it all right? Great, thank you. So for the eligibility criteria, what is the most important in a trial? The most important thing is specifying, obviously, all the selection criteria, but they are with an eye to ensure clinical equipoise, right? Everybody who's included in a trial, there should be no one who is perfect for one treatment versus another. There should be some uncertainty about which of the two treatments is going to benefit that. That's one of the main principles that is for the benefit of the participants, right? Because participants are volunteering their time in a trial, so they should be able to get some benefit. And whether they are receiving placebo or one drug versus another is built into that. They're getting some benefit regardless. So you need to think about whether there's clinical equipoise or not. The same thing will be translated to an observational study. So this is the first step in making sure you're not including individuals who have contraindications for one drug versus another, right? This idea of avoiding non-positivity, structural non-positivity, starts here. You're thinking through who are the people who will definitely not get the treatment or are definitely not eligible to get the treatment, because it's not ethical to include them in your study in the first place. All right, that had to happen. For folks online, there's a fire alarm? This reminds me of a time when I was giving my qualifying exam and there was a fire alarm. I was just like, come on, like of all the times. Thank you, sir. Oh, it's going to continue. Okay. I was like, maybe during this time, there's going to be nothing. Wait it out? Oh, okay. Be ready to run at a moment's notice. Okay, so we were talking about eligibility criteria, right? So in our eligibility criteria, that's the best way. Like at this point, stop and think. The people you're thinking about including in your study, should they be actually randomized to one versus another? Have you made sure that all the contraindications are people with contraindications are excluded? Because that's the first step for a trial. You would never include people in the trial who are not supposed to get the drug at all, right? So a lot of screening procedures take care of that. And that's why the protocol for a trial is so carefully done. Why you should take the same amount of care when you're thinking through an observational design. So first step here. Then we have treatment strategies. So I know we've talked about this a little bit about well-defined interventions. That simply means don't say people with aspirin versus people with clopidogrel. No. People with aspirin between 75 milligram and 325 milligram. With clopidogrel, it's probably going to be a loading dose of some sort for a few days, followed by a regular treatment. How long should the individuals receive the treatment? What are the reasons why a patient may stop the treatment or escalate their dose if necessary? So a lot of times trials do have a lot of detail about their treatments, which is kind of hidden out in the actual protocol. There's a lot more specification about like what is the best process for even somebody, if it's a newer drug that there's not a lot of information out there about, what's the best way to kind of use this information? Perhaps for an antidepressant medication, if you're trying to do a trial, it's not going to be, all right, start at a dose, you can increase the dose in a week. No, antidepressants usually take some time in starting their action. So it is start the treatment, wait for at least a month. In the next follow-up visit, ensure that if the if they're not seeing any benefit, you could escalate the dose to see a higher one, right? So these kind of considerations are oftentimes written out in a trial protocol. That should be information that you also need to think about in an observational study. All right, so just a very quick aside about treatment strategies is if you're reading books about causal inference, or if you've read a few articles that talk about causal effects, you might have noticed these two terminologies come up, which is static treatment regimens and dynamic treatment regimens. Static treatment regimen simply means that the treatment is static, right? So regardless of how many times, let's just say it's a trial for a year, every 3 months, the patients come in for a follow-up. That's the idea. A static treatment is treat at the next time point, treat at the next time point, treat at the next time point, treat, versus don't treat, don't treat, don't treat, don't treat, right? So it is the idea that nothing that's happening over the time period of 0 to 3 months, or 3 to 6 months, or 6 to 9 months, and so on, has any impact on the decision of what treatment to give. It's static. From the beginning, it has been decided this person will always be treated with the drug. This person will never be treated with the drug, okay? As you can imagine, that's pretty strict, right? Because things happen over time. People may develop new indications. They may really need a medication. So which is why most clinical regimens are dynamic. They may start off as treat. Over the period of time, we see benefit. We still see the patient requires that. You still ask them to continue with the medication. You ask them to continue with the medication. Perhaps in the next follow-up visit, they complain of certain side effects that are happening, at which point you decide, all right, it's time to stop. Okay, so this is a dynamic treatment regimen which closely mimics what happens in real clinical practice. Obviously, the problem can be that there are multiple ways in which treatment modifications can happen. There's not just one set thing, right? It's not just like, all right, if you develop bleeding, then you will stop. No, person may also have development of renal disease that might require them to stop, may develop kidney disease that might require them to stop. Perhaps they are just not able to afford one particular drug. In a trial, that would be less of a concern. But in an observational study, maybe they just can't afford the cheaper version, or the version in their formulary, insurance formulary is another one, so they switched over. So there are many different ways in which a regimen can be dynamic, all right? And ideally, a trial usually mentions all of this. Then we have treatment assignment procedures. So if you really think about it, when you are trying to design a trial with an eye of at least emulating that with observational data, you cannot insist on designing a trial to be double blind and all that, right? Because that's not really going to happen in observational studies. Everybody knows what's happening. Patient knows exactly what they're taking. So that's why I mentioned that it's mostly pragmatic in nature as much as possible. So like any trial that you're going to emulate will obviously be something that's open label and everybody's aware of what's happening here, okay? Just to make sure that that is not an obvious discrepancy in the emulation process. And in the assignment procedure, one of the main things to do is to think about when the people are going to be randomized. Let's just say there's a trial which is conducted. So there's actually a point trial that was conducted, which was conducted in folks who had minor stroke or major transient ischemic attack, so some sort of an ischemic event. They came to the emergency. The time that they were randomized was 12, at least based on the trial, it was 12 hours, within 12 hours of abatement of symptoms. That's what it's mentioned in the paper. What does that mean? Obviously, like when the patient is just in front of you, you're not going to be like, yeah, you know what, you're really eligible for a trial. Let me just enroll you right now. No, that's not happening, right? So you have to make sure whatever is the emergency condition is kind of taken care of, because the treatments that were being compared for more long-term prevention of the next episode, okay? So because of that, the assignment procedure was like, all right, the symptoms have stopped. Within 12 hours of that, screen them, make sure they're eligible, and then randomize them, all right? And you can think this is really hard to do with observational studies. Why? There's no code for symptom abatement. There's no way to know when the symptoms are subsiding for folks. You have to take a best guess or try to kind of say like, all right, from admission, most TIAs subside within 24 hours. That is like the old definition, but often a definition that's used, like any event that's an ischemic event, if it subsides in 24 hours, it's kind of diagnosed as TIA. So you could say like, all right, we are going to run like my time of randomization or whatever is the time zero for my observational study is going to be after 24 hours of admission. So you have to work within the constraints of the data sometimes. Then we have follow-up period and outcomes. So follow-up period simply means in a trial, once they are randomized, they're starting to accrue follow-up time. You have to specify how long the study is going to be, as well as when would you consider somebody as lost to follow-up or censored, right? Maybe you have 10 follow-up visits. If they don't show up for the third one, but they show up for the fourth one, is that person still censored, or is that allowed under your protocol? So you have to think about like what censoring criteria would you like to implement in your study. Outcomes, clear definition of what the outcomes are meant to be. Causal contrast of interest. Now this is where you need to figure out what causal contrast that you would like to estimate. Do you want to estimate the intention to treat effect, or do you also want to estimate the per protocol effect? In a trial, obviously, ITT, primary analysis, right? Because the whole point, I mean, not the whole point, but a very big point of doing a trial is the fact that you're randomizing folks. So once you've randomized individuals to one treatment versus another, that just comparing based on what they've been assigned to is what the intention to treat is. You compare outcomes among those who've been randomized to treatment A versus randomized to treatment B, and that comparison will give you the intention to treat effect. But a lot of folks are also interested in the per protocol effect. So as I mentioned, the intention to treat effect is defined as comparing outcomes among those assigned to treatment strategy A versus treatment strategy B. Is there any question about this effect? Right, it's the easiest, it's wonderful, it's great, it's lovely. Okay. What is not so great and lovely oftentimes is the per protocol effect. So per protocol effect is defined as comparing outcomes among those who are consistently following protocols. So consistently following the protocol for strategy A versus consistently following the protocol for strategy B. Why do people not love this? It sounds so great. Well, people don't love this because you could specify a protocol in multiple different versions. And oftentimes, people who are following the protocol versus those who don't follow the protocol, something is happening over the follow-up period time that is not captured in the baseline data. So essentially, when you go to estimate a per protocol effect, you're almost breaking randomization. And that is kind of negating one of the best things about RCTs and all, right? So anytime you are envisioning to estimate a per protocol effect, you have to start collecting data about things that are happening over time, not just baseline data. Okay, so I'm going to go over a little bit more about this concept of ITT versus the per protocol effect. So intention to treat effect is the primary analysis in RCTs. And even in observational data, it's the most common effect that's being estimated. So what you have is simply people who initiate strategy A versus initiate strategy B. That's it. Clear, simple. And in the observational study, like I mentioned, it compares outcomes among initiators of strategy A versus strategy B. So that's what you would have in an observational study. In the per protocol effect, while it is usually a secondary analysis in RCTs, at least recently it has started gaining more focus because we not only want to know what's the effect of telling patients, hey, you take drug A, you take drug B, you also want to know, like, if you consistently are taking that particular regimen or following that particular regimen, do you see benefits or not, right? We want both pieces of information almost. So the per protocol effect in observational studies is a lot more hard to estimate. Yeah, it compares the outcomes among those who are consistently following one strategy versus another. Is that clear? Okay, thank you. So people who like ITT versus people who like per protocol both think it's the best thing since sliced bread. Why? And they're not wrong. I mean, like, both of them are great. So proponents of ITT mention that this estimate most closely reflects real clinical practice. Why is that? Because it's the idea that, like, that is the information that I need when I'm giving a group of people a drug, because not everybody is going to follow what I say, right? Even in real clinical practice, if I'm giving a group of individuals a drug versus another drug, there will always be a few folk who are not adherent to their particular medication or their strategy as time goes on. So this is the most realistic reflection of what is going to happen. Like, if I give a group of people this medication, I'm going to see a 20% benefit in the outcome, potentially, right? So that is why ITT effect is so great, because it gives us a realistic picture of what's going to happen if you treat a group of individuals. Why do people love the per protocol effect? Because it potentially gives an extra piece of information that the ITT does not. It takes into account that some people are not going to be adherent. So it's only going to compare those who are consistently following a drug strategy versus another. So the piece of information that if I, as a clinician, I'm sitting down with a patient, I would want this information is like, hey, if you do what I'm telling you within reason, of course, right? It's compliance. Do what I'm giving this, like, people who've been consistently taking this regimen or consistently taking this medication have found a 40% reduction in their risk of the outcome as compared to, like, in the general population, which includes actual, like, people who are taking the drug versus those who are not taking the drug. It's a reflection of, like, almost 20% reduction in the risk of the outcome. So sometimes patients would not only like to know what's happening in the general population, but what additional information they can get. If I definitely take the drug consistently, am I going to get more benefit or not? Okay. For the ITT effect in a trial, we don't need anything because we have baseline exchangeability. In an observational study, we want conditional exchangeability. We cannot guarantee that, but using our best estimate of what are the confounders, what information that we need from prior literature, from talking to experts, we can get at the assumption of conditional exchangeability. So we still need information on baseline confounders when we want to estimate the intention to treat effect in observational data, right? But for per protocol effect, we not only need information on the baseline covariates, we also need information on the post-baseline covariates, things happening over time that leads people to be adherent to their medication versus not. Let's just say over time, we see that like a lot of people, they are seeing a benefit consistently when they're doing their LDL levels. They're finding that, yes, their condition is improving by a lot. So they're like, all right, this drug is really working. I feel better. I'm going to keep on taking that medication. Versus perhaps sometimes they don't see a benefit and they're like, all right, this is too expensive for me. I don't know what to do. And they stop taking the medication. So there are lots of things happening after people initiate drugs that could cause them to be adherent versus not adherent. And that's a whole talk in itself, right? So both effect estimates are important and give us different pieces of evidence regarding the treatment safety and effectiveness. I hope that was communicated effectively. Okay, great. Any questions? Yes. Okay, that's a great question. I was expecting that question, actually. So the question is the per protocol effect that I described the same as the as treated effect that's often reported in studies, pharmacoepidemiologic studies, right? So what I would say is most of the times, I would consider an as treated effect as a poor protocol effect when you have static treatment regimens, right? Because what do we do when in most as treated analyses, we censor them when they stop taking the drug completely, right? So it's take the drug, take the drug, take the drug, take the drug. The moment you stop taking the drug, even though you have a perfectly good reason to, we censor them, right? So in that case, what we have there is a per protocol effect, but when you're comparing static strategies. That is obviously assuming that the as-treated analyses also adjusts for post-baseline covariates. A lot of times, you may not see a lot of data about that. Perhaps the follow-up is really short. You don't really think of that as important. In that case, it should be fine. But a lot of times, we do want more results to make sure that if there is a common cause of adherence and the outcome, that is important to consider in the analysis. All right, so that's one way. Now, a lot of times people are when they, at least a lot of studies nowadays, what they have is if you're trying to estimate the per protocol effect of a dynamic treatment strategy, that's pretty complex because the first thing is you have to specify that protocol well. Under what conditions is the patient allowed to switch drug? Under what conditions is it allowed in the protocol to stop the medicine? Under which conditions is it allowed in the protocol to stop the medication for a short while, start follow-up again, right? So a lot of people, a lot of physicians, what they might do is if the drug is really essential, they would stop it for a few weeks and then restart it at a lower dose and try and see which one is the best tolerated for a patient. So all of those things for a dynamic treatment regimen has to be specified in the protocol, and it's hard. It's not that easy. And protocol specification is just the first step. To actually implement the dynamic treatment strategy in using observational data is pretty hard. But I know that like a lot of researchers have tried to look at how best to do that. And you can make the protocol as simple as possible, simply saying, all right, over time, if they develop a contraindication, I think that anything after that is left to the physician. They're still following the protocol, but I'm not going to check whether they're stopping the drug, whether they're restarting the drug, whatever. So after that point, they still contribute follow-up time, but they are no longer like, I'm not assessing their adherence. I just assume that once that event happens, anything else is based on the physician's discretion. That's out of my hands because the protocol allows for that specific discretion. So it's very complex. We can have a discussion afterwards if you would like, but yeah, I think like as treated analyses, I would best liken it to a per protocol effect, especially for static regimens. Yes, there's a question.
Thank you. I think so. I'm putting on a clinician hat right now just because I feel like I personally have a bias against per protocol analyses. And when I think about it is if I have people on a medication which has not already had a pharmacovigilance database where I have assessed adverse effects and outcomes that I'm following, and then I take only or consider predominantly a per protocol outcome, I'm actually subjecting my population to potential adverse outcomes. I think of like cisapride, how that was withdrawn from the market due to cardiac effects. And I think that creates a bit of an anchoring bias for us to assume that that difference in efficacy is the most important outcome clinically.
I completely agree with you. So that's a good point. So the question basically gets at this idea of like, under what conditions would it be best to estimate a per protocol effect? Like personally, I find that a per protocol effect for a safety outcome is potentially not the best way to go, like at least for a dynamic treatment regimen, because you do want to stop when they're developing an adverse event to get the real effect of taking the drug versus not. In terms of effectiveness, perhaps you might be a little bit more lenient when you're thinking about a per protocol effect for allowing individuals, because in reality, when a physician is giving a regimen and not just a drug, it involves all of these decisions within it, and that's going to be best reflected as a true real follow-up occurs as well. So I agree, like for safety, I think censoring them when they develop the outcome, even if it's a minor outcome, is probably the best way to go. Versus in effectiveness, you might kind of put that hat on where you're like, all right, I want to see what happens when people are following the advice of a physician, which will involve all of these issues, especially with safety, versus the other regimen. So perhaps that might be a better chance to go.
I agree with the points made. I just one comment or thought, and curious your thoughts too, but what I've seen is a lot of the induction phase or failure to dose intensify, and the studies around that are a little more relevant for this question of per protocol effect. So, for example, are patients getting the right dose or getting enough, or are they dose escalating at the right time? And then the evidence that's used is more for physicians to say, okay, should you actually be giving a higher dose at a certain time to achieve the outcomes that are more similar to a trial? And you see this in diabetes. We saw this a lot. I worked at J&J for a while, so saw this with canagliflozin. Do they dose intensify enough? Or you see it in IBD and stuff like it. They should have the right loading dose and then not. So totally agree with the outcome measures and things. But I think one of the more relevant research questions, and again, curious what your thoughts are on when is the appropriate time to dose intensify to achieve better clinical outcomes?
I very much agree. I feel like that's the next logical step, because I feel like we have a good number of drugs for most of the conditions which are effective and safe. Now, the next thing to think about is what is the best way to use those drugs? And that would be like when to stop them, when to start them, how long to treat folks, what is the time when you increase the dose to make sure that they're optimally taken care of. I know there's a lot of recent controversy, or at least like about statins, whether high dose is better than low medium dose, which is oftentimes the ones that are used, and whether high dose does have more benefit versus not. So I think like that's true, but it's also one of the things that's really hard to do with observational data, short of primary data collection, right? Because if it's the same thing why observational studies about switching or second line medications is so hard to do. Why? Because in the database, all I see is people continuing with the drug versus people who are moving over. In a trial, that's easy. I just recruit everyone who's already taking a particular drug, and I randomize them to like, all right, take a new drug versus continue on the old drug, but that assignment is random. In an observational study, people are switching for a reason. Can you identify the reason? Great. People who are continuing on what they are already on for a reason. right? So that kind of research, while very important, is I feel like we need to think about creative ways in which to answer those specific questions. Any other questions? Excellent, thank you. All right, and the analysis plan will obviously depend on what the causal contrast that you want to estimate, whether it's the intention to treat, per protocol, both, neither, well, not neither, but you know what I mean. So, right, so based on that is your statistical analysis plan and the kind of information that you have. All right, so these are the key concepts that we've covered in the lecture so far. We'll be moving on with the activity. Does anybody have any questions before that? Does anybody want a yoga stretch? I'll take you through. Okay, all right. So in the activity, what we have is we've kind of divided it into 3 phases. The first one is we'll give you obviously a case example, a little bit more detail about that case example. How would you specify a trial? You should have received, and please let me know if you have not, an email yesterday or day before yesterday with 2 handouts. One of the handouts is a table of the target trial specification versus observational study. And then you have another handout which has simple details about what the database that we're going to use, or at least the information that the database that we're going to use for this specific case example. I do have a few printouts, so I'll just be circulating those in case you prefer to write things down right now. So first, we'll spend some time among all of you, thinking about what a trial would look like. The next thing would be drawing the assumptions, like trying to create a DAG for that specific research question. And the last would be, how would you emulate each of the components of the trial using the healthcare data that you have? Okay. So the case study here is statins. We all know they're excellent, they're wonderful, they can cure everything. I mean, not really, but I feel like a lot of times initially it just felt like, yes, they could do everything and anything. They were like the superheroes of pharmaceuticals. So basically they've been used for prevention and treatment of cardiovascular diseases and risk factors. After atorvastatin, we've had multiple different statins being introduced in the market. And now the choice is between not the lesser of the evils, but like the better of them, right? So we have a group of researchers, let's just say they're interested in comparing 2 statins, rosuvastatin versus atorvastatin, with respect to their effectiveness in reducing risk of AMI. So from this statement, what do you know? You know the exposure is rosuvastatin versus atorvastatin. So we have an active comparator situation. It's not a non-user like design. Rosuvastatin versus atorvastatin. The outcome is myocardial infarction. And let's just say this is the first MI. So we are looking at folks because among patients who have one risk factor, that's type 2 diabetes, and don't have a history of a cardiovascular disease. So they've not had any MI in the past, any stroke in the past either. So they are like relatively healthier folks who have type 2 diabetes. And for primary prevention, you want to think about whether these individuals should get rosuvastatin versus atorvastatin with the outcome of MI. All right? So these are the components of the trial. Obviously, please look at them while you're trying to design it. We would like to encourage you to think through the details of the eligibility criteria and the treatment assignment specifically, because that oftentimes are really challenging to emulate with observational data. And this is what the handout looks like. So basically it's a table. Each of the protocol components are on that. So there are 7 protocol components. One section is for specification of the trial, and the second side is for the emulation using observational data. This kind of side-by-side comparison is why we say that the target trial framework is explicit. Like all your faults are laid bare. That's fine, Just because you shove them under the rug doesn't mean they're not there. This is a great way of having a true discussion about what is the best that you could do, what have you done, and what are the fallouts that you see in your data analysis, okay? All right, so this is what we want you to focus on for, how long, Josh? Let's do 15 minutes because this is going to be important, right? So what I would recommend is perhaps you could, based on where you're sitting, 2 or 3 folks could sit together. Obviously, this is meant to be an interactive thing. Bring your knowledge about statins and MI, or bring your knowledge about epi in general to discuss the specific question and how is the best way to specify the trial. Okay, this is the question of interest. All right, well, great. Okay, I'm gonna distribute the target trial like a handouts right now, just so everybody, if they want to type it down, you could do that too.
So spend about 15 minutes. It's okay if you don't get through all 7 components. Let's get as far as we can, and then we'll move on to the next session. But we'll get as far as we can, come back together for a few minutes and discuss before moving on to DAG. So feel free to work with just the people in your areas, as Geeta said.
No, but I think because it needs to be for primary prevention as well, not just secondary. Right? So ideally, you would hold that. Okay, I think just one more minute and then we'll come together. I don't think anybody heard. 2002? All right. People love it, love all the discussion, but let's all come together and reap the benefits of all of this intense discussion. Okay. Wonderful. So again, interactive session. So I will be asking the questions here. It's your turn to talk and my turn to listen. Well, okay. So let's go over each of the protocol components by themselves. And based on who wants to answer out loud, I'm hoping it's a cacophony of noises. But, please let me know what you think, what you've discussed, what's the reasoning behind that. All right. So let's talk through the eligibility criteria. Remember, most important thing, we still have equipoise at the start. There should be no folk who are not eligible to receive one or the other. basics, right? Okay, so what do you think should be the eligibility criteria? Some of them I've already mentioned. How would a trial address these? Let's start basic. What's the timeline of inclusion? Like, when would you start this study? Right, so we perhaps want to start with people who have a new diagnosis of diabetes. All right, okay. And you have individuals who've been diagnosed with diabetes at one point. Is that in the trial, you are expecting people to be immediately randomized to statins, or should they just have a history of diabetes? Right? Perhaps because just to be, you might not even in, I mean, like in a trial, it might be more possible that somebody is coming in with a new diagnosis of diabetes, and then you're thinking about like, all right, let's talk primary prevention, randomize you to one versus another, and that's absolutely fair. It'll be a lot more difficult to do that in observational study, to have that very tight timeline between a new diagnosis of diabetes and a prescription of statins, right? So you have to keep that in mind, like what would be best served here. Perhaps you want individuals who've been diagnosed with diabetes in the last year, just to exclude people who already have, cardiovascular, what is that called? Microvascular and macrovascular complications developing, right? So you want people who've been recently diagnosed with diabetes in the last year. You screen them. What are the other additional criteria? A basic one would be age. Oh, excellent, right? So you want to make sure that like you have folks who are above the age of 18, adults, who have been recently diagnosed with diabetes, perhaps, right, in the last year. And you can obviously design this in multiple different ways. I'm just trying to create a narrative so that we can talk about the observational study. But let's just take that to be true. And one of the criteria that we also want is we want it to be for primary prevention. So individuals, and also the outcome is AMI, one of the first incidents of outcome to be taken into account. So individuals should not have had any myocardial infarction before that. What is the timeline you want to assess? Is it a lifetime AMI? So in a trial, ideally you would want a lifetime AMI, right? Because if you come in, even if the person has had a myocardial infarction in the last 5 years, that changes things drastically, because that's no longer primary prevention at that point, right? So for a trial, you would want people to never have had AMI before in their life, perhaps another cardiovascular disease, perhaps no stroke at all, versus you could include people with stroke depending on how you want to design your trial, right? So these are individuals for whom there's a primary benefit, primary prevention benefit among individuals who've never had a cardiovascular disease before, okay? What other additional selection criteria would you like to have? No history of drug A or drug B, right? They should be new users. They should be recently, like at the point when they're being randomized, that's their first interaction with the statin, basically. So not just drug A or drug B, perhaps you want them to not have had any statins before, right? Any other statins, although I think these two are the most common kind of being prescribed. So you could have a complete washout, no statins whatsoever. What else? Yes. I'm sorry, I can't hear. Okay, so you could have that. That is definitely entering and being more restrictive. So the idea is that in the 30 days before they are being randomized, you don't want people to have had a recent hospitalization, recent sepsis, because that increases the immediate risk of having an MI, and that would be attributed to the statins when it's actually because of something else. So you perhaps might want to like take care of that. So that is a possibility. What else? Yes. Yeah, I think like, so the point was that like we would not have any restrictions on other cardiovascular risk factors, right? So we would have perfect inclusion of individuals with hypertension. We would collect that information, but that would not be part of the eligibility in itself. Yes. Okay, so the question is about whether we should take into account the LDL levels when we are having the inclusion. Now, I don't know if that would technically be considered. I mean, yes, I think we could. In that case, we are specifically like those individuals need statins or are specifically being required to have statins because of their LDL cholesterol levels, and they happen to be folks with type 2 diabetes. So that's a possibility. You could have that inclusion criteria. Excellent point, right? So statins are not given to individuals who have acute liver failure or any kind of decompensation. So that has to be part of your exclusion criteria. What about any? So cancer would, so again, remember, we are trying to emulate a pragmatic trial. So not have too many exclusions unless that's an important thing to consider. Just like you think that cancer is a very important effect modifier and you want to observe that only in patients of cancer, that's a different situation. You could have that. But if you're generally looking for patients with type 2 diabetes, probably if they don't have cardiovascular disease so far, around the 40s, 50s range. So it may not be that much of a concern, right? So you definitely could, but it's also like you have to think about when you talk about cancer, is it a lifetime cancer? What kind of cancer are you excluding? Do you want it to be active cancer versus cancer in remission? All of these things need to be taken into account because at the point of selection, right? Yeah. So in individuals, so the FDA has approved statins for like there are multiple indications for use, right? So some of them could be age related, some of them could be specifically for like they keep adding on depending on what efficacy is proven in different populations. So you could, and this is a concern when you're thinking about off-label use of a medication specifically, is when a drug is being prescribed off-label, there's usually a very specific reason behind that. And are you able to capture that reason? Because there might be other drugs that are perfectly willing that are labeled or indicated for that particular condition as well. So in this case, if it is equal between both rosuvastatin and atorvastatin, both of them are off-label, then that might be an easier thing to like compare as a comparator. But I think in this case, it should be fine. All right, so that's the eligibility, right? Then we are talking about treatment strategies. Now, focusing on well-defined interventions means that you need to think about how the drug is going to be, like what is the actual regimen that's going to be given to individuals. So what do you think? What should be the comparator? Rosuvastatin versus atorvastatin? What dose? How are you thinking about it? Yes. And this is a really great point. So the point was about you could have different regimens that are already being used in practice, right? For some things, you just have a standard thing. For antibiotics, this is the dose that they are given for this duration, which is great for us because we don't need to worry about dose so much. But for most chronic conditions, there is a range of drug that is safe and effective for individuals. And that's where, well, the physicians have that amount to like work with basically. So in many cases, it's not so much the dose, but so much as like Perhaps there is a clear dose escalation depending on how well they tolerate the medication and so on. So you could, in reality, just leave it to the physician. Just say like the trial starts off with 10 milligrams versus another. I don't know what the dose of rosuvastatin is, I'm sorry. But like you could start off with a low dose and adjust it based on what the physician's discretion is. Perhaps you want to avoid the highest dose for primary prevention. I don't know what the situation is going to be like. Perhaps that is not really necessary in this population, but you could have a clear kind of way of saying that, like, these are the dose. We start off with this up to this particular dose for this duration of time. And that is very clear, okay? And based on the follow-up visit and how well the patients are tolerating, as well as whether the target is being met for LDL specifically, you could have that information there. Okay, all right. What about treatment assignment procedures? When do you want to randomize individuals here? Yes. Exactly, right? So you basically, what you have here is a set of criteria. You recruit people. Somebody comes into the clinic. You see that they've been recently diagnosed with type 2 diabetes. They don't have a history of cardiovascular disease. You're like, all right, we have this trial. We want to screen if you're eligible. And if you are, you can participate in this trial. And that way you could go forward. And once you are satisfied all the eligibility has been met, and the informed consent has been signed, then you can randomize these individuals. In many cases, you could have something where a disease and a drug are linked, right? So you could have something where, like the example I mentioned of TIA, high-risk TIA, and the start of an antiplatelet agent, that has to be within a few hours or days of each other. So that could be a lot more linked, and in that case, the trial would have to reflect that. Okay, all right. Follow-up period, how long do you think you should follow individuals up in the trial? 2 years, 6 months, 5 years? Remember the outcome. Based on your targeted number of events, and how long does it take to impact the event, right? So perhaps you might see more of an impact immediately if you've had patients who've recently had MI for a repeat MI. If your age range of individuals is like late 30s, 40s, 50s, perhaps you want the follow-up to be longer to accrue more events, right? Then the causal contrast of interest. I'm assuming you want the ITT effect, right? Do you want the per protocol? No, I understand. Okay, so I will be discussing some components of per protocol. You're not getting away that easily, but all right, I'm not gonna ask you to give me a lot of information about that. I'll just tell you how to best go about that. Okay. The analysis plan, like I said, in a trial, if you are just estimating the ITT effect, you're kind of okay, right? You just need make sure that the whatever the variables that you've collected are balanced. Ideally, like there are two different thoughts on whether you see an imbalance, should you adjust for that or not. Some people are like, don't touch the randomization, it's done. Some are like, you know what, I see this thing imbalance, I want to adjust for that. You could do that. And also in the analysis plan, you would put in like, are there any subgroups you want to investigate? What are the subgroups that you want to investigate? This is the place to put all of that information in. Are we okay with that? Tentative plan? Yes. So that's a good question, right? So what if, now that when you're comparing rosuvastatin versus atorvastatin, you have to think about like, what are the safety profiles of each, and is there a reason for somebody to switch one to another in the middle of, let's just say, a 2-year trial? What would be the best reason for that? In some conditions, these two drugs are very similar to each other, right? In terms of their contraindications, safety profile, everything. Like if they do end up developing a side effect, let's just say rhabdomyolysis, would you switch over to another statin, or would you just like stop and be like, all right, let's try something else, right? So in that case, you need to, it really depends on the context of the study. Here we can say, let's just say in the protocol, we are specifying that like somebody has an outcome, a safety issue, we're just going to censor them, versus just say like, if they have a safety issue, the physician does what they want, and we'll, if we want to estimate the per protocol effect for the effectiveness, we need to take that into account. Yes. Yes. I mean, like, yes, it's an ideal trial, but it also needs to meet the standards of any trial that's actually going to be conducted. Even if we are doing it as a thought experiment, you need to be able to allow individuals to leave if they have to. Just because. Mhm. So I completely agree with you, right? So the question was about like when people discontinue, it's for a multitude of reasons. It's because they're no longer interested in participating. It's because they are interested in participating but not interested in taking the drug, versus it's a safety issue, they have a contraindication, and so on. So in a trial, usually they have even in a pragmatic trial where you don't have a lot of strict follow-up, you definitely have something like an exit interview where you kind of try to understand why do you not want to be participating. Sure, you're ready, like it's okay if you leave, but tell me why, or at least give me an indication of why. Is it because this has happened, and so on. And that also brings up one additional component, right? Because just comparing the risk of outcome among one versus another, it's not going to be as simple if you have lost to follow up for other reasons. You need to take that into account in the analysis as well. Are you going to use censoring weights? Do you think that people leaving the study is informative or non-informative, right? Like people who leave the study versus those who stay in the study, are they similar to each other? Is it random? And you can do all of that investigation when you simply look at their profiles. You might see that people who are leaving the study, they are just healthier and they're like, I don't see much benefit. I'm okay. I think everything else is good. I'm just going to leave. Versus those who remain in the study, they feel like they really need the study. Perhaps the other way around can also happen, right? So it really depends. You can do a lot more investigation once this has happened, like get information about people who leave, compare the characteristics of the people who leave versus those who remain, and in the analysis, you might do a time to event analysis, but you would still need to adjust for the fact that in that case, those who remain in the study can't be directly compared. You need to account for the fact that they're being censored for some reasons. Yes. So the question was about like there are certain like SNPs, so like in the enzymes that could lead people to choose one versus another or have more side effects on one versus another. Now that's like in at least in a trial ran at that point of randomization, they're distributed well, but they may be experiencing more side effects. And frankly speaking, at that point, the question is like how frequent is this in the population? How much is this? Because remember, we're not how much ever you want to, we can't talk about we're comparing groups of individuals that are reflective of the population that they're going to be given in. If the standard practice, that's true. Like even the other drugs that they're being given, that could also like lead to more interactions, causing more side effects and so on. So that's a good point. So I feel like there are like if you think it's a major issue, you could do a test at the beginning and stratify, look at subgroups, one versus another. But most of the times, people don't do it all that much in this case, anyways. right? So I think it's just a matter of how much moolah do you have. And in most observational studies. Okay? All right. Thank you so much. I love the discussion. Now we go to DAGs. We have some time, don't worry. We'll get to
All right, we're going to abbreviate this part of the session, but the next ask is that each of you will draw a DAG for the observational version of the study that you just designed. So we're going to specify the exposure as rosuvastatin. It's going to be rosuvastatin versus atorvastatin. So that'll be your A. I'm giving you a head start here. Your outcome is going to be the acute myocardial infarction outcome. And what you're going to do is draw your A and your Y, and then any other study variables that you think are important to consider for the observational study that you're going to design to emulate that trial that you just designed. So you specify your variables, and then you're also going to condition on the variables that you want to control for in some way, either via design through restriction or via adjustment in the analysis. You're going to put your box around the appropriate variables. And just to give you, for those of you who don't have deep clinical knowledge in this area, we've given you an example of risk factors for myocardial infarction that you might consider as potential variables to include in your DAG, and I'll leave it at that. And what we want you to do is maybe take about 5 minutes to draw it, and then right before we come together, I'll give you about a 1 or 2 minute warning to have a look at your DAG and try to apply the rules of deseparation to figure out whether you have any bias in your DAG that's unresolved. Okay, so take about 5 minutes to design it, and then I'll give you 2 minutes to review it, and then we will discuss what you've come up with, and I'll leave these rules up here as you go about it. Is this slide more helpful to view? Okay. All right, if you haven't moved on to reviewing your DAG for potential biases, why don't you go ahead and do that? You've got about 2 minutes and we'll pull it back together.
All right. Well, thank you for all the discussion again. I feel like this is a good group of people who don't mind talking to each other. This is great. Okay. So let's go to the DAG. I have an example of the DAG. Your DAG might look slightly different. We can discuss the reasons why, but I think we're short on time a little bit, unfortunately. Okay, so what we have is, in this slide, I'm just laying out everything, right? So I have the exposure, rosuvastatin. I have the outcome, AMI, and I have all the various confounders, potential confounders there, right? So remember, for confounding to be present, you should have a common cause of A and Y. So there should be arrows going from the variables to both A and Y. In this case, we're fairly certain that you have this arrow, right? These are all risk factors for myocardial infarction. We have that already. What about the arrow into A? Remember, it is rosuvastatin versus atorvastatin, not rosuvastatin versus nothing. It's not a non-user design. If it was rosuvastatin versus nothing, all of these arrows would go from each of these variables probably into rosuvastatin as well, right? Because like the choice, what does that arrow mean? It means that if somebody is of older age, if somebody has high serum cholesterol levels, in that case, they are more likely to receive rosuvastatin versus nothing. That's what that arrow really means, right? In this case, because it is rosuvastatin versus atorvastatin, now the question arises, are any of these conditions good enough for you to prefer one drug versus another? Okay, and that's the question here. Like, do any of these variables lead a physician or a healthcare provider to prescribe atorvastatin as compared to rosuvastatin, or rosuvastatin as compared to atorvastatin? Healthcare utilization, and what are you thinking about that? So it really, so the point made was like, depending on the formulary, you know, they may have tiers. While the lower tier might be atorvastatin, the higher tier might be rosuvastatin. Need prior authorization. There's so much in the U.S. healthcare system, right? Where before you can get a drug. Now in this case, it really depends. First of all, is that level of detail, at least if you're thinking about in the observational study to identify all of this information, you probably do not have, right? So you might have a collective group of folks who have a healthcare condition. If you are getting this information from a hospital chain, in that case, you might have people from all different types of insurances, and you might not have the level of detail that you think that you need here, right? So you might not know what level of formulary that is. That's why it's oftentimes really difficult to kind of measure that using a secondary databases specifically. Sure, if you're doing primary data collection, you can identify everything. But for secondary, yes, that's a bit more difficult. Yes. Sorry, could you please speak up? Okay, so that's again coming back to the point of the metabolizing enzymes. So let's just say that I think the question was, if we exclude everyone who already is on an important or a potent CYP3A4, which is the most common metabolizing enzyme inhibitor. Because if we exclude everyone who is there, then in that case, the decision to choose, like, then we kind of remove the probability that even if they have a mutation, that's going to impact the side effect. I think that's the point. I think that is a endeavor. Like, what are the important inhibitors? That's an important question. Are there commonly used drugs? Are they commonly used conditions? You have to kind of weigh who are the people you're leaving out versus the benefit that you're going to get by using that kind of a design. And I think you could go either ways. That's not, I'm not saying that that's not a good enough, that would be the eligibility criteria. If all of those individuals who already are taking any kind of an potent inhibitor are excluded, then you could completely have that. And then in that case, you don't have as much confounding as you think you're going to have. And in that case, if you don't have that, then you have to consider a U, which is basically something that's unmeasured, that's going to lead you to select one versus another. But the next question is, how important is that with respect to your outcome? Is that mutation increasing your risk of MI? Right? So that's also an important thing to keep in mind. All right? Now you would have noticed that, let's just say that we're adjusting for all of them. And again, you have lots of schools of thinking. Some say only adjust in your analysis the variables that are truly a common cause of both exposure and outcome, versus others might say that, all right, as long as you're not including variables that are only associated with the exposure, you can still put it in the model because those are instruments, if you kind of know that. So let's just say right now we're adjusting for everything. But in my data, I do not have serum cholesterol levels, right? I don't have the data for serum cholesterol levels. What I have is perhaps a diagnosis of dyslipidemia. Now, this comes to this idea of, like, the DAG is meant to represent the world that you're living in, which with respect to an exposure outcome relationship. You need the DAG to be as complete as possible. Put in every variable you think that is important. Now, whether each of those variables are measured or not is another story. In many cases, we might not be able to measure serum cholesterol levels, but we might be able to measure a proxy of serum cholesterol level, right? In this case, it might be people who are diagnosed with dyslipidemia. They have abnormal lipid levels. Perhaps that is a good enough proxy way which will still take care of the path between serum cholesterol levels, exposure, and outcome, but without directly measuring serum cholesterol levels. So with the kind of healthcare databases that we have, we're always relying on proxies to do the adjustment. We don't have BMI. We don't have like most of the lab values, most of the x-rays that we might need. So we need to keep our kind of detective hat kind of on when you are thinking through drawing a DAG, and especially what variables we need to measure and adjust for in order to get the causal effect. Okay. So do you want to take the last one, please?
All right, so we are at time. We had a really robust discussion today, so I want to thank you all for that. There are great discussions within the groups and a really terrific discussion at the group level as well. So thank you all for coming. Thanks for persisting through both a water main leak and a false alarm on the fire alarm, and for really sticking through this material. I do have 3 points I want to make before we conclude. One is you have homework. So the homework is this third part of the activity here, where within the worksheet, you should feel free to really think about how you would specify the observational analog of the randomized trial that you designed. We will, in several days, follow up with a completed version of that worksheet, so you have something to compare to, at least some set of considerations to compare to. There are not necessarily right and wrong answers, but at least you'll see one way of thinking about it. Point number 2 is there is an advanced topics course later this afternoon that Miguel Hernan is putting on. It really follows on nicely with a lot of the concepts that we discussed this morning. So hopefully if you're attending that course, you'll be able to make some pull-throughs and linkages between what we discussed and what Miguel will discuss. And then thirdly, we really appreciate and value your feedback. And this is the second year we've offered the course, and we're looking forward to the feedback that you'll provide in the evaluation. Please tell us what you thought worked well, what we can do to improve so we can continue to improve the course next year. You should be receiving that evaluation as part of the overall ICB survey that will be sent out. So we look forward to your honest feedback there. Thank you all very much. Enjoy the conference, and thanks for your great participation.
Very quickly, just want to let you know that we'll be sending out the completed form based on what we've discussed by probably early next week to everyone. And along with that, if you go through that and you have more questions, you want to clarify something, please feel free to email back to both me and Josh.